Good morning, everybody, and I welcome you all to day 2 of 20th Annual Shaukat Khanum Cancer Symposium. We will be starting our day today with one of the most challenging and exciting fields in cancer care, which is gastrointestinal cancers. In last couple of years, we've seen a global paradigm shift in the care of GI cancers, and some big leaps have been taken in GI cancer, whether it's advances in minimal surgical techniques, diagnostic strategies to improve the diagnosis and early detection of cancers, innovation in radiotherapy, or last but not the least, whether we talk about immunotherapy, which is proving to be a big game changer in the treatment of advanced GI cancers. So I am here, Dr. Tabinda, clinical oncologist from Shaukat Khanum Hospital, Lahore, will be host for your this session. And I am joined by Dr. Syed Irfan Kabir, who's a consultant hepatobiliary surgeon from Peshawar, and we will be hosting you for next two sessions for GI cancers. I would like to thank all my guest speakers for taking their time out and accepting our invitation to be part of this wonderful gastrointestinal sessions. I would request the audience to grab their cup of coffees and be seated, because for next 2 hours, I can assure you that you will not be able to move from your screens. So without any further delays, we'll start our session. And I would like to invite our first speaker, Dr. Muhammad Fawadul Kamar, Dr. Fawadul Kamar. Dr. Fawadul Kamar is a consultant radiation oncologist and a service lead in Shaukat Khanum Hospital, Peshawar. He will be talking about paradigm shift in non-surgical management of esophageal cancers. Welcome, Dr. Fawad, and over to you now.
I would like to welcome you to Shaukat Khanum Memorial Cancer Hospital N1 Symposium. My name is Dr. Muhammad Fawadul Kamar, and I'm currently working as a consultant clinical and radiation oncology in the hospital. Today, I'm going to talk about a very important and interesting topic, which is the paradigm shift in the non-surgical management of patients with esophageal cancer. So just to give you an overview, we are going to briefly talk about the epidemiology of the disease, with changes in the TNM staging, 8th edition, the current standards of management, the role of neoadjuvant and definitive chemo radiotherapy, role of radiotherapy dose escalation, role of immunotherapy, briefly going to talk about the role of surgery and some of the organ preservation approaches. Esophagus cancer is the 8th most common type of cancer worldwide and the 6th most common cause of cancer death. Cumulative risk from birth to age 74 is about 1.14% for men and 0.43% for women. Globally, it affects nearly 500,000 people worldwide. The most common histological subtypes are squamous cell and adenocarcinomas, with the former being the predominant subtype, although the incidence of adenocarcinoma is also rising significantly. So as you can see in this figure, that the incidence of esophageal squamous cell carcinoma is particularly common in China, Asian subcontinent, Central and South Asia, Sub-Saharan Africa, and South America. Most likely etiology being diet, use of nitrosamines, tobacco use. So TNM, the 8th edition of TNM has made quite a few advances in terms of staging of esophageal cancer. So there have been advances in both local and distal staging of esophageal cancer. There also have been different staging for patients with squamous and adenocarcinomas owing to difference in their biology and also in their survival. They've also used multiple modalities, including esophageal gastrointestinal, CT scan, endoscopic ultrasound with or without fine needle aspiration, endoscopic mucosal resection, FDG PET, and EBUS techniques to better stage this cancer. All of these modalities have a complementary role in staging, with the aim of accurately staging the tumor and to guide the treatment. However, each modality has got its own limitation. And grading, although it is not a component of the 8th edition, but it is likely to be included in the 9th edition of TNM staging. So just going to briefly talk about the current standards of management. When we are seeing a patient with esophageal cancer, we look at different things, including the disease biology, disease location, what stage it is, and also more recently, we're also looking at molecular biomarkers to guide our management. Similarly, in terms of patient factors, we look at their performance status, how well are they, their comorbidities, and also their wishes and expectations. So, role of neoadjuvant chemoradiotherapy. We all know that neoadjuvant chemoradiation improves outcomes in some patients. It also increases pathological complete response rates and reduces the risk of local recurrence, along with improving survival. Different chemotherapy regimes have been established, including carboplatin and paclitaxel, Cis5FU, cisplatin and capecitabine. However, the optimal neoadjuvant regime has not been established. So this talk would have been incomplete without mentioning the landmark CROSS trial. So this trial basically defined the standard of neoadjuvant chemoradiation in patients with esophageal cancer. So essentially, this trial included 363 patients with esophageal and gastroesophageal junction cancers. Predominant cancer type was adenocarcinoma, and they were either randomized to preoperative chemoradiotherapy with a combination of carboplatin and paclitaxel with radiation dose of 41.4 gray in 23 fractions, followed by surgery or surgery alone. And we all know that the 5-year survival, overall survival, was significantly better in favor of neoadjuvant chemoradiotherapy arm, and median survival was 49 months versus 24 months, so almost double with the addition of chemoradiotherapy in the neoadjuvant settings. So this survival curve beautifully demonstrates the results of the CROSS trial and clearly indicates the superiority of chemoradiotherapy on plus surgery as compared to surgery alone. And this benefit has been observed both in squamous as well as adenocarcinomas of the esophagus. Now, interestingly, the 10-year follow-up data of CROSS trial has been published, and it clearly indicates that at 10 years post-follow-up, neoadjuvant chemoradiation still offers 38% survival benefit as compared to 25% benefit with surgery alone. And also, looking at this curve, we can clearly appreciate that when we combine neoadjuvant chemoradiation with surgery, then the risk of death from esophageal cancer is greatly reduced as compared to surgery alone. So how about definitive chemoradiotherapy? So RTOG8501 is a very old trial, but effectively it established the role of chemoradiotherapy in definitive settings versus radiation alone. And essentially it was a 1-to-1 randomization between chemotherapy plus radiation dose of 50 gray concurrent with cisplatin versus radiotherapy alone at an escalated dose of 64 gray. And the trial clearly demonstrated that the combined chemoradiation offered superior survival as compared to radiation alone. Still, you can see that even with combined chemoradiation, there were 44% locoregional failure with definitive chemoradiation. However, overall chemoradiation was superior to radiation alone. Then comes another landmark trial, RTOG9405 or INT0123 trial, which was a phase 3 trial of combined modality treatment for esophageal cancer, effectively randomizing standard dose of radiation with high dose of radiotherapy. And it was a very important trial, which effectively, there was a 1-to-1 randomization between either standard chemoradiation with a standard dose of radiotherapy of 50.4 gray, or a dose escalated arm with radiotherapy dose of 64.8 gray, combined with chemotherapy. The trial actually showed that the survival in patients in dose escalated arm was poorer as compared to the standard dose of radiotherapy. So effectively, it was a negative trial. and escalating the dose of radiotherapy did not improve survival in definitive chemoradiation settings. So now this begs the question, is dose escalation feasible? Now, with the advent of modern radiotherapy techniques, including IMRT, rapid arc, and tomotherapy, we could potentially improve therapeutic ratios by escalating the dose to our target while minimizing the dose to the surrounding organs. We can also better use modern imaging techniques, including PET-CT scans and EUS, to help delineate us our radiotherapy target. And there is also increasingly promising role of immunotherapy in combination with radiotherapy. And this really is a very promising new step towards improving the outcomes in this group of patients. So VMAT or rapid arc and tomotherapy can improve our target definition, and it can potentially spare our surrounding organs. So this could essentially be a very interesting thing to look at, especially in clinical trials, where we could potentially escalate dose to our targets with the use of these modern radiotherapy techniques. Also, PET-CT scan can greatly improve the nodal staging and also help in our radiotherapy volume definition. It can also be a very good approach to assess our response to treatment of the standard dose of chemoradiation, especially if we are considering organ preservation as an approach. I'm going to talk more about it in the next few slides. Immunotherapy. So immunotherapy has really revolutionized the way we are looking at cancers. CheckMate-648 trial was a randomized phase 3 study looking at a combination of two immunotherapies, so nivolumab plus ipilimumab, or nivolumab combined with standard chemotherapy, or chemotherapy alone in patients with unresectable, advanced, recurrent, or metastatic, previously untreated, so treatment naive patients with esophageal squamous cell carcinoma. So it was a very interesting trial because it especially looked at the role of immunotherapy in patients with metastatic or unresectable disease. And the trial beautifully demonstrated that the combination of either two immunotherapy drugs, so nivolumab or ipilimumab, or combination of nivolumab with chemotherapy is superior in terms of offering a better survival advantage as compared to that of chemotherapy alone. So the primary endpoint, the survival was 15.4 months with nivo chemo combination and 13.7 months with ipi-nivo combination versus just 9.1 months with chemotherapy alone. And the results were statistically significant. So then the role of nivolumab was tested in adjuvant settings in this trial, and essentially it looked at whether adjuvant nivolumab did improve progression-free survival in patients with resected esophageal or gastroesophageal junction cancer. So it was recently published in 2021. So this trial clearly demonstrated, CheckMate-577 trial clearly demonstrated superiority of nivolumab versus placebo alone in patients with resected esophageal cancer. And you can clearly demonstrate, see that this benefit was observed both in squamous as well as adenocarcinomas. So in patients who do not achieve pathological complete response after neoadjuvant chemoradiation, addition of nivolumab does significantly improve progression-free survival in these patients, regardless of their histological subtype. So you can see that nivolumab and immunotherapy in general has now crept its way from metastatic to adjuvant settings. Then we would want to ask the question, is there any role of combined radioimmunotherapy, especially when we are treating patients with radical chemoradiotherapy alone? And this cartoon clearly indicates that when we irradiate esophagus or any tumor that could potentially create an abscopal effect. So the dying cancer cells can release a number of antigens which are taken up by the antigen presenting cells, who then present it to the T cells, and then you activate the immune pathway and effectively activate the effector T cells, which in turn can target the cancer cells, causing abscopal effect. So the addition of immunotherapy can effectively unblock these immune checkpoints and activate the T cells, and hence increase this synergistic effect of immunotherapy and radiotherapy, causing improved, enhanced cell kill, and can potentially increase the effect of radiation and potentially also reduce any micrometastases. So there are interesting ongoing phase 1 and 2 studies exploring the role of combined radiochemoimmunotherapy in patients with unresectable locally advanced esophageal cell carcinoma, especially squamous cell carcinomas. Then we would ask the question if there's any role of surgery after chemoradiation. Surgery is the only way to reliably assess pathological complete response. As I've mentioned, that all the imaging modalities, including EUS, CT scan, and PET-CT, are still not able to distinguish between post-radiotherapy fibrosis or inflammation from any viable residual tumor. However, surgery does carry a treatment-related mortality, especially after chemoradiation, and the risk has been quoted in the region of 2 to 10%. However, surgery is still considered a standard of care after neoadjuvant chemo radiation, especially in patients with lower and mid-thoracic esophageal cancers. So this trial, FFCD 9102, looked at the role of surgery after chemoradiotherapy. So it effectively included 445 patients with locally advanced esophageal adenocarcinomas or squamous cell carcinomas, with the latter being the predominant subtype. They all received induction chemotherapy with combination of fluoropyrimidine and a platinum. And then they had either 46 gray of treatment in 4.3 weeks, or they had 30 gray split course of treatment, i.e. day 1 to 5 or 22 to 26. And then they were re-evaluated. So out of 444 patients, 259 patients had a response, and then they were randomly assigned to either surgery or further continuing chemoradiotherapy. So then they had further courses of Cis5FU with either 20 gray of radiation or 15 gray of split course radiotherapy. So effectively, this is a survival curve which clearly demonstrates that there was no statistically significant benefit from the addition of surgery to chemoradiation in this group of patients, especially in the ones who have responded well. The ones who did not respond to chemoradiation were offered surgery if they had no distant metastases. But for the responders, addition of surgery did not improve survival. How about salvage surgery, i.e. those patients who recur locally after neoadjuvant or radical chemoradiation? So RTOG0246 trial was a phase 2 study of Taxol-based chemo in combination with radiotherapy and selective surgical salvage. It included 43 resectable esophageal cancers, patients including both adeno and squamous cell carcinomas. So in terms of the trial schema, all eligible patients, they received 3 chemotherapy drugs, including 5-FU, cisplatin, and paclitaxel, followed by chemoradiation with 5-FU and cisplatin, and radiotherapy dose of 50.4 gray in 28 fractions. Then they were evaluated, and if there was any residual or recurrent disease, then they were offered selective surgery. So if they had response, then the surgery was omitted. So only in the settings of residual or recurrent disease, they had selective surgery. So a total of 44%, that is 18 patients, underwent surgery, and 17 out of those 18 patients had residual tumor. The median follow-up was 16 months. There were overall 4 treatment-related deaths, and overall survival at 1 year after salvage surgery was 71%. However, it did not meet the hypothesized 1 year's projected survival of 77.5%. So that was considered as a negative trial. So the conclusions were that salvage surgery does not improve survival in the settings of recurrent or relapsed disease after definitive chemoradiotherapy. So how about adenocarcinomas? Now, HER2 overexpression, it does occur in about 12 to 15% of patients with esophageal adenocarcinomas, and it does present as a very good target in combination with chemotherapy for patients with HER2 overexpressed esophagogastric cancers. So we had a landmark TOGA trial, which used a combination of chemotherapy with trastuzumab versus chemotherapy alone in patients with advanced esophagogastric HER2 overexpressed adenocarcinomas. And it clearly demonstrated that addition of trastuzumab with chemotherapy is better than chemotherapy on its own. And there was a 3-month survival benefit with addition of trastuzumab with chemotherapy doublet. Then how about a role of HER2 therapy in neoadjuvant settings in esophageal adenocarcinomas, which are HER2 overexpressed? So we had RTOG1010 trial, which combined trastuzumab to trimodality treatment, including chemoradiotherapy plus surgery, versus trimodality treatment on its own. And unfortunately, it was a negative study, so there was no benefit of adding trastuzumab with trimodality treatment in improving disease-free survival. Now, it begs the question, can we actually skip surgery in patients with esophagus cancer? It is a possible option in patients with excellent response following neoadjuvant chemoradiotherapy and those who are unfit medically or they're unwilling for surgery. However, it requires very intensive follow-up, including CT scan, EUS, and OGD surveillance post-treatment. PET-CT is also very useful for response assessment. Unfortunately, all these modalities could still miss local recurrences. So this was a very interesting trial, Prisano Trial, published in 2018. It was a phase 2 prospective multicenter study which effectively looked at the detection of residual disease after neoadjuvant chemoradiotherapy for esophageal cancer. And effectively, the trial concluded that after neoadjuvant chemoradiotherapy for esophageal cancer, clinical response evaluation with regular OGDs, with bite-on-bite biopsies, endoscopic ultrasounds, and fine needle aspiration of suspicious nodes was adequate for reduction of local regional residual disease. And PET-CT scan was also useful for detection of any interval metastases. So this trial effectively did set the bar for ongoing evaluation of patients who could be considered for organ preservation. This strategy is currently being tested in a multi-center phase 3 trial called Prisano Trial, or surgery as needed for esophageal cancer. And essentially, those patients who have achieved complete clinical response as guided by imaging post-treatment and OGDs are being randomized to either vigorous surveillance with OGD, with bite-on-bite biopsies, EUS with FNA and PET-CT scan, or to surgery. However, organ preservation approach is more resource intensive. It requires a very high level of patient compliance, and in developing settings, it is a very costly approach to take. Still, this trial opens a venue for patients who are at high risk of surgery after having neoadjuvant chemoradiation, especially in patients with borderline fitness. However, these patients need to be rigorously followed. And if they're suitable for surgery, they need to be offered surgery if there's any evidence of local recurrence. We have to bear in mind that all of these imaging modalities have got certain pitfalls. For example, bite-on-bite biopsies can still miss about 10% of local recurrences, and PET-CT scan can still miss about 10% of local and distant metastases. So we have to take all of this into account. And of course, we need to take into account patient wishes as well. So just to conclude, we have achieved great progress in the management of patients with esophageal cancer over the last decade. Although dose escalation of radiotherapy is not yet a standard option based on a number of negative trials, but with the advent of modern radiotherapy techniques, especially tomotherapy and rapid arc techniques, we could consider dose escalation, especially to our boost volumes in order to improve disease control and potentially to also to improve survival. There's a very promising role of combining immunotherapy with standard radiochemotherapy to improve our outcomes. We have already established the role of immunotherapy in metastatic and adjuvant settings. There's also a great role of chemoimmunotherapy and even different immunotherapy combinations in patients with metastatic squamous cell carcinomas, which has greatly improved the outcome for this group of patients. And finally, we could consider organ preservation for a selected group of patients, especially those who have achieved excellent response of the chemo radiotherapy and who can potentially take on a vigorous course of follow-up with different imaging and endoscopic modalities. So these are some of the references, and I thank you very much for listening to my presentation, and we would take any questions at the end. Thank you.
Thank you very much, Dr. Fawad. This was a comprehensive overview of trimodality treatment in esophageal cancer. We'll have the question answers at the end, and I would request the audience if they can type their questions in the chat so that we can direct them to their respective speakers. I would like to invite our next speaker, Professor Rebecca Fiscard, who's a consultant gastroenterologist from Addenbrooke's Hospital, Cambridge, UK. She is also a program leader at the Medical Research Council Cancer Unit at the University of Cambridge and the co-leader of CRUK Cambridge Institute Early Detection Program. She has done a lot of work and which mainly focuses on the early detection and treatment of esophageal cancers. And I welcome you to this symposium, and the talk of her presentation for next 25 minutes would be innovative approaches for early diagnosis of esophageal cancer.
Thank you very much for the opportunity to present at this Shaukat Symposium. Today I'm going to discuss innovative approaches for early detection of esophageal cancer. And in particular, I'm going to describe the work we've done on a new diagnostic approach called Cytosponge. And therefore, these are my disclosures. I'm a patent holder for Cytosponge and related technologies that have been licensed to Covidian, now Medtronic, and a co-founder of Cyted Ltd, working on early detection technology. So let me first introduce the clinical problem to you. And the starting point is that esophageal cancer is often diagnosed late. And if we look at the stage of cancer diagnosis from 1975 to 2015, you'll see that the situation really hasn't changed much over that time. And most cases are diagnosed with regional, shaded in red, or distant disease, shaded in green. And at that stage, the outcomes are often very poor. We know, on the other hand, that diagnosing this cancer earlier dramatically improves survival and also reduces the morbidity of the associated treatment. So compared to cancer that's relatively advanced, even though those that we put down a potential curative pathway, stage T3, where we tend to treat with chemo radiotherapy and surgery around a 3 to 6 months treatment, when it's diagnosed early at a superficial stage, intramucosal, even submucosal carcinoma, T1 disease, we can treat this as an outpatient via endoscopic therapy with really excellent survival rates. So early diagnosis seems to be a key aspect to improving outcomes from this disease. Now, this is a very tractable problem because there is a pre-cancer condition, Barrett's esophagus, that precedes esophageal adenocarcinoma that's invasive. This is the endoscopic view of non-dysplastic Barrett's. These are views looking down towards the stomach. And in non-dysplastic Barrett's, this is a metaplastic condition where the normal squamous esophageal lining is replaced with this columnar metaplasia characterized by goblet cells. And that can progress to low-grade, high-grade dysplasia and intramucosal cancer in some patients. And you can see the progression rate per year. So a relatively low progression rate for non-dysplastic Barrett's, 0.3% per year, so 1 in 300 patients per year. That increases substantially as dysplasia develops, up to over 13% per year for high-grade dysplasia. And because of this, all the guidelines now recommend that when dysplasia is developed and is being confirmed by independent pathologists, we should intervene and treat endoscopically at that stage. And that's because, as I've already said, the survival rates are dramatically different depending on the stage of diagnosis. Now I'm going to talk mainly today about screening, that is a proactive invitation to patients who might have undiagnosed Barrett's. But we shouldn't forget that in order to improve outcomes, we also need a more timely diagnosis in patients with symptoms referred for endoscopy. Often endoscopy is delayed or it doesn't happen. Patients are just treated symptomatically. And the other aspect is patients with known Barrett's esophagus who have regular surveillance endoscopy or monitoring to detect dysplasia, and often that isn't done to the standard that's required to really improve outcomes. So all of these three aspects need to be improved in order for us to really move the needle on this poor prognosis disease. So we need to do more proactive screening, timely diagnosis and symptomatic referrals, and high quality surveillance. So the question is, how should we perform this screening and monitoring? Endoscopy is obviously the current gold standard, but there's no systematic screening program to look to identify Barrett's esophagus, and therefore the majority of patients, estimated over 80% of patients out there with Barrett's, are never diagnosed. Most individuals suffering with heartburn do not even see a doctor. They can get medication often over the counter. Quality Barrett's surveillance is somewhat variable. There is sampling bias in the endoscopies taken from the Barrett segment. You need a good pathologist to ensure that the diagnosis is robust, particularly as dysplasia develops. An endoscopy, although straightforward, is relatively invasive, requires a day off work, and has therefore costs associated with it. So what I would like to put to you is a somewhat new paradigm for a targeted approach to screening for Barrett's esophagus. So what I mean by this is a pyramidal approach in which we take individuals from the general population and we first identify who is at risk. This could be done perhaps by a simple questionnaire based on the current known risk factors, which I'll discuss briefly. We then take the at-risk population and we perform a triage test to identify who is really at high risk, who needs an endoscopy. And this triage test should ideally not be done with endoscopy, which should not be affordable on this scale, but should be done using a minimally invasive non-endoscopic cell sampling. So let's first of all think about who should have screening, who is at risk from this cancer type. We know that the prevalence of Barrett's esophagus increases with the type and the number of risk factors. So heartburn symptoms, the main indicator we have of reflux disease, the prevalence of Barrett's in that group is around 3%. We know that the risk increases with age and in male. If we have individuals with heartburn and one other risk factors, for example, age over 50 or male sex, then the prevalence of Barrett's significantly increases to around 12%. Family history is a strong predictor, but the majority of individuals do not have any family history. So when it's there, it's helpful, but for most individuals, it will not be informative. So most of the international screening guidelines tend to be predicated on the idea of GERD plus one risk factor. Nevertheless, we know that there are a proportion of individuals who don't have heartburn symptoms who could be missed by this approach. So it's a matter of finding that sweet spot between increasing the prevalence and enriching the population versus what's opening the gates wider and really screening a larger proportion of the population, but in a way that's affordable. So in the work that we've done, we have generally worked on the basis of heartburn symptoms and therefore patients taking medication for those symptoms. we have opted for patients over 50. We haven't discriminated between men and women. So having considered who to screen, the next question is how to perform that screening test. And there are a number of considerations about the type of device and the assay, including safety, acceptability, the cost, ease of administration, stability of the device and transporting the sample, having a reproducible and certified assay in the laboratory that's really as highly sensitive and specific. For screening, you really want to maximize the specificity as a rule-in test. As a diagnostic for patients with symptoms, you want to maximize the sensitivity. And I'm going to talk mainly today about screening, as I've said. So our approach to this has been trying to think outside the box and come up with a new non-endoscopic approach using a device coupled with a highly sensitive and specific assay. We've developed a sponge on a string device called Cytosponge. There have now been several such devices being developed, including a balloon type device called Esophagus. Several different assays can be applied, including methylation, microRNA, cytopathology, immunohistochemistry. And we have really focused on a slide-based technique using immunohistochemistry as well as cytopathology, because we think that this gives the maximum amount of information for the patient and to inform management. So this cartoon just illustrates really the idea of our Cytosponge TFF3 test. TFF3 is the biomarker which I will describe to you in comparison to endoscopy. So endoscopy, obviously a skilled procedure, usually conducted in a hospital setting by a skilled clinician aided by nurses, in which you have a visualization of the esophagus via the endoscope and then a targeted biopsy of areas of interest. The non-endoscopic Cytosponge is a very different approach. We're having no imaging with this device. We're simply going to retrieve cells along the whole length of the esophagus and then analyze it in the laboratory. This is a very easy to administer test that can be done in an office setting outside of the hospital. So usually in our hands, administered by a nurse, the nurse asks the patient to swallow a capsule tethered to a string. The capsule will go into the stomach and dissolve, and out will pop the sponge, the spherical sponge, which has been compressed previously in that capsule. So the sponge is then retrieved by the nurse by withdrawing the thread. And as it comes up the esophagus, the sponge will collect a large number of cells, both on the surface of the sponge and within it, that you can then use for analysis. And this is a pan-esophageal test. So this little cartoon just shows you how this works. So here's the capsule descending on the thread down into the top of the stomach. And in the more moist environment, the capsule will dissolve over just a few minutes and out will pop the spherical sponge. This can now be withdrawn by the nurse, collecting cells from the gastric cardia and along the whole length of the esophagus for analysis. So you then have a mixture of squamous cells and glandular cells, and these often come out in sort of clumps. So we've done a lot of work to look at the different aspects of this device, including the acceptability, safety, and the performance of the assay. This slide just summarizes our multi-institutional Cytosponge data, a systematic review performed by our own lab and also an independent group. And this was on over 2,600 procedures. First of all, to note that it's quite an easy device to swallow. The risk of complications, people worry about detachment of the sponge from the string. That's less than 1 in 1,000. And if it does detach, it can be easily removed at endoscopy. It's not a big deal. Side effects, the most common side effect is a sore throat, which is usually very mild and short-lived. About 4% required some simple lozenges or medication, painkilling medication, just to deal with the sore throat. So really a very straightforward, simple device. How acceptable is it? We ask patients to rate that on this visual analog scale between 0 and 10, where 0 is awful and 10 is very enjoyable. The median is around 6, with interquartile range of 5 to 8. If we compared that to endoscopy, then obviously it depends whether you're sedated or not for your endoscopy, but generally Cytosponge is pretty well tolerated, particularly when we compare it with endoscopy without sedation. In the BEST 3 randomized trial, which I'll describe for you in a moment, the median acceptability score was actually 9, interquartile range 8 to 10, and that was data collected a week after the Cytosponge, and 97% gave a score of 5 or higher, where 5 is sort of neutral. So really very well tolerated. Turning to the biomarker, this is a very important aspect because you collect a lot of cells on this device, over 1 million, and you then have to determine from this pan-esophageal sample whether or not you've got Barrett's esophageal metaplasia there, which is characterized by these goblet cells. And you also want to see if there's dysplasia, ideally. So this assay needs to be performed to a clinical lab standard. It needs to be easy to score and assess, and it needs to be affordable. And these are all things that we considered when we were developing the assays. So the cells are removed from the sponge by washing. We then pellet them down, and we generate a clot using a plasma thrombin mix so that the cells really clump together. We can then embed that into a standard FFPE block to perform standard histological sections. You end up with a kind of pseudo biopsy, which you can analyze by standard H&E, as well as immunohistochemistry. And the marker that we focus on is trefoil factor 3. This gives you an idea of the H&E appearance of the sample. Several factors to note here. You have the normal squamous epithelial cells, a whole clump of them here from the normal esophagus. The gastric cells are very useful quality control because that tells us that the device has truly reached the stomach, which is essential for us to be sure that we have sampled the distal esophagus. And this is an example of some Barrett cells. This is a gland containing the pathognomic goblet cells. Now, while you can see these on H&E, the task is much simplified if you have immunohistochemical staining. And to discover the best Barrett's biomarker for the pathognomic intestinal metaplasia, we first of all did a microarray gene expression experiment, done some time ago now, to distinguish signals from Barrett's compared to gastric cardio and squamous epithelium, where we wanted something highly expressed in Barrett's, but not found in gastric cardio and squamous epithelium. We came up with a number of candidates and developed an antibody, and trefoil factor 3 proved to be the most specific, with a nice clean staining. Now, the immunohistochemical assay also allows one to apply machine learning to automate or semi-automate the analysis. And so a computer algorithm can identify that there are columnar cells present as a quality control. It can then give the pathologist an estimate based on the identification of the TFF3 positive cells about whether they think that there is Barrett's esophagus present or not. And this then dramatically increases the speed at which the pathologist can triage through the sample. So how sensitive and specific is the Cytosponge TFF3 assay? This was a case control study comparing TFF3 on cytosponges in patients with known Barrett's compared with controls. And in a per protocol analysis, the overall sensitivity was around 80%, increasing to 87.2% for greater than 3 centimeters of segment, and the specificity 92.4%. So you might ask, why do you not get a higher sensitivity? And that's in cases where the cytosponge doesn't reach the stomach. So if you offer a repeat cytosponge, if the capsule doesn't reach the stomach, then sensitivity is up around 90%. So really a very encouraging sensitivity and specificity profile. And based on these data for the following trial, BEST3, if the cytosponge didn't reach the stomach, we didn't have these gastric cells present, we offer the patient a repeat to really maximize the sensitivity. And so that led into our randomized control trial, BEST3, in which we had more than 13,000 patients randomly divided into 2 groups. Half in the standard of care group, in which the family doctor did whatever they would normally do, treat the patient's reflux symptoms, offer them an endoscopy if they felt that was clinically indicated. And the other half were all offered the Cytosponge. So this was pragmatic, multi-site randomized controlled trial. And the primary endpoint was to see if offer of Cytosponge TFF3 for patients on medication for reflux would detect more Barrett's esophagus than standard of care. Secondary endpoints were stage of cancer detection, safety, acceptability, and the health economics. So over 13,000 patients were enrolled into this one-to-one randomization. 39% of patients were interested to take part. And in the end, when we took into account inclusion-exclusion criteria, ability for us to schedule the patient, 24% actually consented to swallow Cytosponge. The safety was excellent, and I've already shown you the acceptability data, which was superb. So here are the main results from the BEST-3 trial. The primary endpoint was whether we would detect more Barrett's in the Cytosponge arm compared to usual care. And you can see here that we detected 140 cases of Barrett's with Cytosponge compared to 13 in usual care, giving us a ratio of over 10. This was an intention to treat analysis based on the offer of a test. So this is taking into, this is data in which only 24% actually swallowed the Cytosponge. And even with that, there was a tenfold increase in the proportion of Barrett's esophagus detected. So obviously, if we could get that acceptability and the acceptance rate of actually doing the Cytosponge up higher, we might detect even more cases. So this means that 13% of patients swallowing the Cytosponge required an endoscopy. And when they had an endoscopy, the chances of us finding Barrett's or associated dysplasia was 59%, so positive predictive value of 59%. Bear in mind that most endoscopies for patients with reflux are normal. So this was a significantly enriched result, enriched population. Thinking of our pyramid of approach, if we find the at-risk population, we offer them a triage test, and then we only endoscope the high-risk individuals. So this just breaks down the data for you in a bit more detail. You can see here that those offered the Cytosponge, the intention to treat analysis, most of the cases were found in those that actually swallowed the Cytosponge versus those that were offered it and didn't swallow it. And this included patients with early disease, low-grade, high-grade dysplasia, stage 1 carcinoma, who all had curative intervention. There were some advanced cases detected in the usual care group with stage 3 and stage 4 cancer. So although the primary endpoint was not to look at stage of diagnosis, it looks as if offering the Cytosponge would detect more cases at an earlier stage. And we hope that this would improve long-term outcomes and mortality. So I think I've shown you that Cytosponge TFF3 has a good accuracy, safety, and acceptability profile. We now have randomized controlled trial evidence compared with usual care. And I'm not presenting the health economic data today, but that also looks favorable with additional qualities at lower cost. So what are we aiming for? We're really aiming for precision diagnosis. We want to identify Barrett's, but we have dysplasia or cancer or not. We could endoscope all these patients with a TFF3 positive result. That's what we did in the BEST-3 trial. But ideally, if we could use additional markers, we could divide those patients into low risk versus high risk, and then only perform endoscopy on those we really think are high risk who are likely to need treatment. So how could we do that? Well, our lab early on thought we could hopefully use a panel of mutations to identify those at high risk. But when you look at the spectrum of mutations in this disease, it's highly heterogeneous. And furthermore, when we compare patients with never dysplastic Barrett's to those with high-grade dysplasia and cancer, you find that even those with never dysplastic Barrett, showed in the grey bars, have a smattering of mutations in bona fide oncogenes, even though they'll never progress. P53 is very discriminatory and is only really mutated in patients with high-grade dysplasia and esophageal adenocarcinoma. So we went on to develop a panel, but this was based on some clinical factors and a fairly straightforward abnormal copy number or aneuploidy is also informative, and we used an immunohistochemical marker for that, aurora kinase A. And in this initial study, that enabled us to divide patients into low, moderate, and high risk based on that panel. And we did a discovery exercise and then a small validation cohort. So this was encouraging, but we were a bit disappointed with the proportion that fall into the moderate risk group, because from a management point of view, that's not so easy to advise the patient. Much easier if we know you're truly low risk or truly high risk. Compare the copy number profile from indolent Barrett's who progress, and esophageal adenocarcinoma. You can see that while the indolent Barrett's is very flat, the progressors and those with cancer have a lot more copy number aberrations, where gains are seen in green and losses are in orange. So if we could directly measure that, we would have a better assay. So we did a study to see if we could measure abnormal copy number using shallow whole genome sequencing. So this is sequencing the whole genome, but at low depth to about 0.4x coverage, which makes it a much more clinically applicable and affordable assay. This was done on biopsies with the aim that we would then progress to Cytosponge. In this study, we took patients who progressed to cancer after more than 1 year of follow-up compared to patients with Barrett's who didn't progress. And we had 3 years of follow-up at least for these to know that they were very stable. And this is gives you an overview of the copy number profiles from the non-progressor samples, that's 424, compared to the progressors. And you can see here how much more abnormal the progressors are compared to the non-progressors. And this is in advance of the progression. So these progressors have not yet progressed to the cancer. Detection rate for Barrett's. And I think the holy grail really is to move on from this even further and add additional biomarkers that can risk stratify patients and identify dysplasia, with potential for surveillance as well as screening, and to minimize endoscopy bottlenecks. So I hope that that's been interesting. Here are the fantastic team who have contributed over many years to this work. There are many more individuals as well, but these are some of the key players who I've worked with very closely on this project. And we've been funded very generously by a number of funding agencies, in particularly MRC, Cancer Research UK, the University of Cambridge and the NIHR. Thank you very much for your attention.
Mic is mute.
We'll be sharing the slides later on because I think a lot of the viewers couldn't see the slides, so once we receive them, apologies for that. Moving on the theme of organ preservation. In rectal cancer, there is a gradual shift towards avoiding surgery in those who have pathological complete response from radiotherapy and chemotherapy. However, this does come with a significant pelvic dysfunction. And in order to help us understand the principles that are involved in the management of this organ dysfunction, we have Professor Andreev, who is specifically well known as being the first gastroenterologist at the Royal Marsden, where he was involved in treating GI side effects of cancer treatments. Professor Andreev did his medicine in 1987 from the London Hospital Medical College, and then followed this up with a PhD as a fellow for British License Foundation. He was subsequently a senior lecturer in 2000 in Imperial College London, and then worked as a consultant gastroenterologist at Royal Marsden. In 2016, he was elected faculty at the Institute of Cancer Research, UK, and in 2017, he landed the prestigious Nemo Professorship at the Royal Adelaide in Australia. He has substantial research profile and enjoys a worldwide reputation as a clinical innovator and a pioneer of new treatments. So over to Professor Andreev, and I'd like to hear how we deal with organ dysfunction following radiotherapy.
Hello, my name is Jarvis Andreev. I'm a gastroenterologist in the UK, and I've been asked to talk to you about the very important but often neglected topic of bowel dysfunction, and today specifically after pelvic radiotherapy. In my clinic, I would normally see about 6 women like this every week. This was Kirsty, 33-year-old, who was 8 weeks pregnant when she had a scan which showed suspicious changes. After a lot of heartache, it was decided that she would just be absorbed. And 4 months after she delivered her baby, she was diagnosed with stage 2B cervical cancer. She underwent an ovarian transposition, which, as often happens, was unsuccessful, and then chemoradiation. And previously, she had had lifelong normal bowel function, and there was no past history apart from this cancer. When I met her, she had constant nausea. She vomited 2 or 3 times a week. She had an extremely noisy belly. She was getting very severe cramps. She had dreadful wind, which was really quite offensive and very difficult socially. She had this feeling of an orange or a melon stuck all the time in her bottom. And she varied between having her bowels open once a week through to 6 times a day, often with very marked urgency. And at her very young age, after her cancer treatment, she was being incontinent once every 2 weeks. Her stool consistency varied between loose and liquid, and sometimes she had steatorrhea, i.e. fatty stool. And intermittently, she would have episodes of bloating and vomiting with terrible pain, where she went into subacute obstruction. In addition, she was getting a lot of urinary bleeding with very big clots. She was exhausted all the time, and her relationship with her husband had almost disintegrated because of the pain she would have on intercourse. And she'd previously seen another gastroenterologist who had done a colonoscopy, and as often is said in this situation, the colonoscopy doesn't show anything untoward, so nothing can be done. Go away and be grateful that you're cured of your cancer. So this is a very big problem, especially as you oncologists out there are curing more and more people who have to live with such debilitating symptoms long term. So when you look after people like that, there are three particularly unhelpful concepts which are rife in the community. First of all, that because of the symptoms that people are getting after radiotherapy, typical symptoms are very clearly diagnostic. And I hope to show you in the next few minutes that that's not true. The second thing that as a clinician, it's very important to understand is that while surgery and radiotherapy are touted as local treatments, they really aren't. In this era of intensity modulated and VMAP radiotherapy, the whole bowel is getting a dose of radiation, which potentially can have an effect. And even surgery to the pelvic floor can change small bowel motility. And thirdly, there's this fixation that people have just got a single underlying problem, while after radiotherapy, that's absolutely not the case. So when you're managing these patients, there are 5 key steps to undertake to understand, to help these people. First of all, you need to understand what symptoms people are likely to develop. And we have described, after careful studies in patients, 22 different symptoms which are common after radiotherapy, and they're listed here. And while you as a clinician might be worried or interested in the bleeding, this isn't necessarily what the patient is interested in, because when patients present, they're presenting with multiple symptoms, and what they want is they want all their symptoms to be dealt with. In addition, what we can see in people coming to my clinic, while everyone had GI symptoms, many patients had other issues. So if you focus just on one system, you're not going to help the patient adequately. You have to be holistic. So after understanding the types of symptoms people get, which are many and all of them need treating, the second step is to start to understand what individual symptoms mean. And I would like to suggest to you that they mean very little indeed. For example, let's just think about diarrhea, one of those 22 symptoms. And you can see on this side, there's a whole list of different causes of diarrhea, and over here, how frequently they happen during and after radiotherapy. But diarrhea is diarrhea. I, as an expert who talks about diarrhea all day long to my patients, I have no idea what the cause of their diarrhea is without investigating them. So the third important thing to start to understand is that it's not the pathology within the bowel which causes symptoms. It's whether that pathology changes gastrointestinal physiology. And this also, if you can understand this, this becomes a completely different approach to this patient group. So if you have any insult, and in this case, radiotherapy, it can cause a lot of different pathological changes, some of which are listed here. But there's excellent evidence that pathology by itself in the bowel correlates very poorly with the symptoms that people will then experience. And instead, if you change pathology, it sometimes it affects specific gastrointestinal physiology. And when this physiology is altered, that is what causes symptoms. So what sort of physiological changes am I talking about? Well, here's a representation of the gut. And if you insult it, many different physiological changes can happen. So in the upper gut, people might then have a problem with absorption of specific carbohydrates, be it lactose or possibly fructose or sucrose or whatever. They may have a problem with malabsorption of fat or of bile, or they might start finding they have bacteria growing in parts of the bowel where there shouldn't be bacteria, and the whole series of other physiological changes which can happen. The fourth thing to consider is that often these patients appear to have very complex symptoms. And I've already shown you that your average patient is going to have 10 or more symptoms ongoing at any one time. But it's very easy to deal with this if you start to think of complex symptoms as just multiple different simple symptoms which are all happening together. And if you think of one symptom at a time, then suddenly this complex group of people start to be straightforward to manage. Because for each of the 22 symptoms that can arise from the gut after radiotherapy, you can define a list of causes. And then for each of those causes, you can think of a list of tests which you could carry out to see whether that physiological change has happened. And if it has, then you could define a sequence of treatments. And we have done that in multiple publications. And what you find that if you identify each symptom accurately, it's like a building block. You build them up one by one, and you arrange the appropriate tests to identify which deficits are present, causing that symptom, and that gives you very obvious treatment options. And what you need to do is you need to be very systematic as you do this. And this is a flow diagram which explains our systematic approach to managing patient symptoms. So in 2012 and 13, we carried out this randomized trial of using this very systematic checklist-based approach to manage patients with new symptoms after pelvic radiotherapy. And this was a group of patients who were said to have untreatable symptoms, which had started after radiotherapy. And we published our results in the Lancet. And in this trial, we asked whether following a comprehensive management algorithm for new onset symptoms after radiotherapy, did it work? And secondly, because there are so many of these patients, we asked whether if these patients are looked after by a specialist nurse who's trained to follow the algorithm, can they get a result no different to that managed by a gastroenterologist? And thirdly, because people said, oh, it's going to cost a lot of money, we wanted to see the cost of it. And in this trial, we showed that, yes, an algorithm was incredibly effective. Yes, a nurse could manage 92% of patients as effectively as a gastroenterologist. And yes, it was really cheap to sort these patients out and make them much better. £1,500 was the package of care required on average in this patient group. And that is considerably less, very considerably less than the money spent on their cancer treatment in the first place. So remember Kirsty, this 30-year-old who had her awful symptoms. What we found when we did a holistic needs assessment was actually she was significantly psychologically disturbed, in fact had a psychiatric disorder and was suffering from post-traumatic stress. which the psychiatrist treated with a range of drugs. She was profoundly anemic, which no doubt made her feel absolutely lousy, and transfusion was required. She was markedly iron deficient and did very well with an iron infusion. She was long-term vitamin B12 deficient now, which makes people feel absolutely awful and happens in 1 in 5 of all people treated with pelvic radiotherapy. So it should be checked routinely. And a urologist was very quickly able to sort out her bleeding from her bladder. She really benefited from support from a gynae nurse specialist. And because she had been so unwell, her work troubles were really becoming an issue, and we could help her with that with a supportive letter. And from a gastroenterological point of view, she had 2 major issues. She had severe bile acid malabsorption, and she had small bowel bacterial overgrowth, a very common disorder in patients treated with immunosuppressive drugs. And both of these are immensely treatable and very simple to diagnose using appropriate testing. And very quickly, this woman who had been previously dismissed by a gastroenterologist and told that because her colonoscopy was normal, she had to live with her symptoms for the rest of her life, was very, very much better. And this spider diagram shows our top 10 symptoms that we were getting in our side effects of cancer treatment. On the vertical axis here is a percentage of affected people. So you can see in green, the percentage who had this problem to a moderate or severe extent at the time they came, and in blue, the number who had the symptom at the time we discharged them. So the most crippling symptom of all in our patient group is urgency of defecation. And what you can see is we didn't sort it out for everyone, but we reduced the frequency with which it was happening in this patient group. And the same for flatulence, same for bloating, same for abdominal pain, all around a huge improvement from the time people came to when we discharged them. And of course, after very radical, complicated treatments to cure patients of their cancer, there is a cost, but you can often ameliorate that cost by doing very simple and sensible things. So the 5th key step that I'd like to pass on to you is that you have to be systematic in your assessment of this patient group. So if they're coming to your follow-up clinic, use a tool like the Alert B screening tool. So you don't even need to talk to your patients about their side effects. If they tick the boxes yes here, then you would automatically refer them to your specialist gastroenterologist to deal with their problems. Get your patients regularly to fill in a holistic needs assessment. And it's very simple as they wait in your waiting room for them to do this, because with the result of that, you can pick up other things and refer them on to the appropriate place. When they come to the gastroenterology clinic, we use what's called the modified GSRS. It's an incredibly simple patient-scored tool, and it helps us assess their symptoms at the start, what tests they need. It shortens the consultation by 10 or 15 minutes, and you can use it sequentially to see whether you're winning or not making any progress, and follow the algorithm. And we've published this both in Frontline Gastroenterology, but also Macmillan Cancer Support have published it, and I hope you might be able to download it yourselves if this is what you want to do. And it walks you step by step through the things you need to do. Many people come to our clinic and say, yeah, you're doing too many tests, you're being too complicated, we know what's going on, why bother with all these things? So we did this study. We looked at about 50 new patients, and when we had taken the history from them, we as experts in pelvic radiation disease predicted what we would find, and we predicted 92 diagnoses. But we still followed our algorithm, and when we followed the algorithm, rather than 92 diagnoses, we made 168 gastrointestinal diagnoses in these 50 patients. And what we found, that only 1 in 4 of the diagnoses we predicted were correct. And what we also found was 2/3 of the patients had 3 or more diagnoses contributing to their symptoms. And in that patient group, no clinician predicted the correct combination. So if you follow an algorithm, it's quick, it's cheap, it's accurate, and you have good results. If you guess, if you behave like the overbearing clinician who knows better, then you won't make progress. With this patient group, they lose confidence and they don't get better. And this is one of the most important papers I have read in the last 20 years. It's published in the JCO. It's a very simple letter. And what it says is that we will not make progress in oncology unless we change our paradigm. And we need supporting services to help the oncologists with the inevitable toxicities they cause, not because they're wicked people, but because that is the cost of curing the cancer. And the most important and the most neglected supporting person at the moment is the gastroenterologist. So you need to develop that service. So to conclude, toxicity is inevitable. Therefore, you must have robust management pathways for the people who get that toxicity, because otherwise you're letting them down. You will not make progress unless you are very systematic, and you need to invest in specialist services because the needs of these patients are quite different from those coming to some other gastroenterology services. And listen to the patients. If you listen to them, they'll tell you what they want sorted out. Thank you very much indeed for listening. I hope this helped your understanding.
Very much. We're going to move on to our next speaker. So pancreatic cancer in itself is a difficult disease to treat and manage. We are honored by having Professor John Neoptolemus to do the next presentation on the role of adjuvant and neoadjuvant treatment for resectable borderline or locally unresectable pancreatic cancer. Professor Neoptolemus is a professor of surgery currently at the University of Heidelberg in Germany. Prior to that, he did his medicine at the University of Cambridge with a double degree in medicine and philosophy, which is not that common. He trained in Guy's and Thomas Hospital in London and then became chair at the University of Liverpool between 1996 and 2017. He served as chairman for the SPECT trials and had a significant role in the SPECT trials 1, 3, 4, and ongoing 5 trials. The results of these trials have been adopted worldwide and have been used as standard for the management of pancreatic cancer. He also established the NIHR Liverpool Pancreas Biomedical Research Unit, Liverpool Experimental Cancer Medical Center, and Liverpool Clinical Trials Unit. So very well versed in the trials setup and completion. He's also holder of Lifetime Achievement Award from the European Pancreas Club, Hirschberg Award from the American Pancreas Society Association, and the Ruth Brofsky Award for Pancreas Research. He has over 78,000 citations and has achieved over 70 million pounds in grants. So certainly knows what he's talking about, and we will hopefully learn how to better manage pancreatic cancer in the current climate. So over to Professor John Neoptolemus.
Ladies and gentlemen, it gives me great pleasure to be presenting here at the 20th Shaukat Khanum Cancer Symposium, and I will be talking to you today about adjuvant and neoadjuvant treatment for resectable, borderline, and locally unresectable pancreatic cancer. I'm Professor John Neoptolemus from the University of Heidelberg in Germany, but formerly spent 20 exciting years at the University of Liverpool. Here are some disclosures that I have that aren't particularly controversial. Quality of evidence is based on well-conducted prospective randomized controlled trials, and I shall focus on these for resectable pancreas cancer with adjuvant and neoadjuvant trials, for borderline and or resectable pancreatic cancer with neoadjuvant studies only, and finally for locally unresectable pancreatic cancer, there are no randomized controlled trials, and therefore the focus here has to be on cohort studies. So, resectable pancreatic cancer and adjuvant therapy. The question is, what adjuvant therapy? Chemotherapy, chemoradiotherapy, or a combination of chemoradiotherapy and chemotherapy? The SPAC1 trial was established to answer this question in a 2x2 factorial design in which patients were randomized to chemotherapy, yes, no, and the same patients were also randomized to chemoradiotherapy, yes, no. This enabled an efficient trial design so that with some 289 patients, we were able to answer both questions. With regards to chemotherapy, chemotherapy was significantly superior to no chemotherapy. However, with regards to chemoradiotherapy, there was no evidence to support this, and if anything, there was a worrying trend towards decreased survival if patients also and/or received chemoradiotherapy. During the development of SPAC1, there was the introduction of gemcitabine for patients with metastatic pancreatic cancer. And in the SPAC1 trial, we used 5-fluorouracil with folinic acid. So the question obviously was, can we use one or the other? Is one superior to the other? Or are they of equal efficacy? And perhaps somewhat surprisingly, we found no differences in the survival curves between these two monotherapy regimens. What was even more interesting was that the median survival rate pushed up to 24 months in both groups. Naturally, there was then the possibility of combining fluoropyrimidines, i.e. 5-fluorouracil, and gemcitabine, and there was mechanistic evidence to suggest that there might be synergy in such a combination. So this set up the SPAC4 trial, and very pleasingly, we found that there was a significant overall survival, significant difference in favor of the combination chemotherapy compared to monotherapy with gemcitabine. The effect was particularly strong in patients with R0 resection margins, and patients with negative lymph nodes also had a very good survival rate of around 50% at 5 years. During the conduct of the SPAC4 trial, a French and Canadian joint consortium undertook the PRODIG-24 trial and showed that using a 4-drug combination of FOLFIRINOX, that is folinic acid, 5-FU, irinotecan, and oxaliplatin, that they could achieve an estimated 50% 5-year survival rate compared to approximately half of that with gemcitabine. It should be noted, however, that these patients were highly selected, as we shall see in a moment. Patients had to be less than 80 years of age, had to have a complete bill of health because the regimen of FOLFIRINOX is actually very toxic, requiring multiple hospitalizations in many patients. Now, there are two important reasons why it seems that the FOLFIRINOX regimen is superior to gemcitabine and capecitabine. One is that the survival was better in both arms in the PRODIG-24 trial, and this is because they had very selective inclusion criteria. Secondly, as we can see in the table on the right-hand side, there was a heavy use of second-line chemotherapy. So at the very first suspicion that recurrence had occurred, they would immediately move on to gemcitabine in the case of FOLFIRINOX or FOLFIRINOX in the case of gemcitabine. To get a sense of how well survival has improved with adjuvant chemotherapy, we should look at the overall 5-year survival rates in the SPAC1, 3, and 4 trials. You can see that with no chemotherapy, i.e. surgery alone, we have an estimated 8% 5-year survival rate. Patients receiving chemo radiotherapy, an estimated 10.8% 5-year survival rate. If we now have monoadjuvant chemotherapy, either 5-FU or with gemcitabine, the estimates improve from around 15.9% to 21%. If we now have a combination of both gemcitabine and capecitabine, we can see a 5-year survival rate of 28.8% estimate. The real impression, I think, is given by the Kaplan-Meier curves, where you can see a steady improvement in 5-year survival rates going from immediate surgery with or without chemoradiotherapy up to the combination of gemcitabine and capecitabine. These trials involve nearly 3,000 patients, and translated worldwide, we are talking about the saving of tens of thousands of lives. More recently, there has been an attempt to combine gemcitabine with Abraxane, made by Celgene. Its generic name is nab-paclitaxel. In the APAC trial, there was no evidence that this particular combination worked. It should be borne in mind that Abraxane was actually developed for metastatic disease to concentrate within the stroma, and obviously when there is no way in the much of stroma, because you've had a resection, it may be that that is a reason why it's not so efficacious as it is in the metastatic setting. In any case, the Federal Drugs Administration have not licensed Abraxane for use in the adjuvant setting, and of course it shouldn't be used. We need to make mention of the Jsap05 trial, where they used a combination called S1. Now, S1 is actually a component with 3 different agents, including a prodrug for 5-FU and 2 other agents that minimize toxicity of 5-FU in the gastrointestinal tract on the one hand and in the liver on the other hand. So effectively, it's possible to deliver a high therapeutic dose to the cancer cells, but with less toxicity. And indeed, they showed a median overall survival rate in their selected group of patients, again, of 46.5 months. So this is resection followed by 6 months of S1, gave a 46.5 month survival rate, not dissimilar to FOLFIRINOX. If we look at key prognostic factors in the 4 trials that I've just mentioned, PREDICT24, SPAC4, Jaspac01 and APAC, you can see that patients in SPAC4 are indeed non-selected, very high R1 rate, a very high N1 rate, and the fewest number of patients with a normal carbohydrate 19.9, which is related to tumor burden. So I think we need to be cautious about how we interpret all these data, but certainly the combination of gemcitabine and capecitabine is quite effective, as is S1, as is FOLFIRINOX, bearing in mind that FOLFIRINOX is actually very toxic. So let's move on now to resectable disease and look at 2 neoadjuvant trials. The first of these is the Jsap05 trial. This is neoadjuvant chemotherapy in patients with resectable pancreatic cancer. What they did here in this trial was to give gemcitabine and S1 in the neoadjuvant setting, followed by surgery, and then followed by S1 in the adjuvant setting. What can't be explained in this trial is the fact that adjuvant S1 in the Jaspac trial that I've previously mentioned had a 5-year survival rate, a median survival rate of 46.5 months, whereas the Priop trial had a median survival rate of only 26.65 months. So it's difficult to explain. This trial has only been presented at ASCO. It has not appeared in published form, despite the fact that it's 2 years now. The next trial in this grouping is the use of neoadjuvant chemotherapy for resectable pancreatic cancer from North America, from the Southwest Oncology Group funded by the National Cancer Institute. And here they randomized 147 patients to receive either FOLFIRINOX or gem/nab-paclitaxel in the neoadjuvant setting. There was no difference in overall survival, but it should also be noted that only 70% of patients having gem/nab-paclitaxel actually had a resection, and only 73% of those having FOLFIRINOX actually had a resection. The authors concluded that this phase 2 trial did not demonstrate an improved overall survival with perioperative chemotherapy compared with historical data from adjuvant trials in resectable pancreatic cancer, and recommended not to use neoadjuvant therapy for resectable disease. Moving on to studies that are looking at borderline resectable disease, there are 4 studies to look at. The first of these is a small surgical series from Japan that randomized patients at the time of laparotomy if the surgeon thought the disease could be removed despite its locally advanced nature, and were randomized in the operating theatre. 20 went ahead and had resectional surgery, and 22 had radiochemotherapy. The survival difference favoured the use of surgery, and the authors recommended that upfront surgery should be the treatment of choice in patients with locally advanced but potentially resectable disease. A more recent study is the Priop Trial from Holland. It's a multi-centre trial where patients either went directly to surgery and had 6 cycles of gemcitabine. A curious choice in itself, as we already knew by the time this trial had started that gemcitabine and capecitabine was superior to gemcitabine alone. But they went ahead with this anyway and compared this with neoadjuvant gemcitabine and chemo radiotherapy, followed by additional cycles of gemcitabine. The primary endpoint you can see in the top left-hand corner was overall intention to treat, and the study was not significant. Even more worryingly in this trial, only 72% of patients had immediate surgery, when this should actually be closer to 100%. And 60% of patients who had the neoadjuvant chemotherapy, only 60% proceeded to resection. What's even more worrying is if we have a look at the Kaplan-Meier survival curves for metastasis-free survival and local disease-free survival. Here we can see on the red line that a large proportion, 25 to 30% of patients in the upfront surgery group already had metastatic disease and or locally advanced disease at the time of randomization, indicating a serious randomization imbalance and poor staging. So whatever differences we are seeing, they are not due to treatment. SKMCH&RC in borderline resectable pancreas cancer provides the best evidence for the use of neoadjuvant therapy in patients with borderline resectable disease. This trial had an accrual target of 100. It achieved 90 before the study was closed. 32 patients went to immediate surgery. 20 had gemcitabine and capecitabine neoadjuvant. 20 had FOLFIRINOX neoadjuvant, and 16 were randomized to chemoradiotherapy. Overall, there were 66% of patients went to resections, even though they were borderline resectable, compared to 55% in the neoadjuvant group. There was a significant improvement in overall survival. 42% 12-month survival for the immediate surgery group, but 77% survival at 12 months for the neoadjuvant group. And if we look at the different categories, we can see that FOLFIRINOX and GemCap have very similar 12-month survival rates, superior to chemoradiotherapy and or superior to immediate surgery. Finally, we have the Alliance A21501 trial from North America, Southwest Oncology Group. And here 126 patients were registered to receive either neoadjuvant FOLFIRINOX, then surgery, then adjuvant FOLFOX, or modified FOLFIRINOX plus chemoradiation, then surgery, and finally FOLFOX. Note that only 49% of those that had FOLFIRINOX went on to pancreatectomy, but this was only 35% had a pancreatectomy in those that had the chemoradiation. Full completion of surgery was achieved in 31% of the patients that had neoadjuvant FOLFIRINOX and 18% in those that had FOLFIRINOX and radiotherapy, presumably due to cumulative toxicity in the latter group. The efficacy endpoint in this trial was an improvement in the 18-month survival rate of 13% over a historical rate of 15%. In other words, could they achieve a 63% 18-month survival rate? This was indeed the case for the group that were randomized to neoadjuvant modified FOLFIRINOX, but was not the case in the group that was randomized to neoadjuvant FOLFIRINOX plus radiation. Finally, moving on to locally unresectable pancreatic cancer, there are no randomized controlled trials, and in this case we have to look to large single-center cohort series, and the largest by far and away is that from Heidelberg, my current institution. It should be borne in mind that Heidelberg is a very high volume pancreas center, the largest in the world as far as we are aware, excluding China perhaps, I'm not entirely sure. But here we undertake between 60 and 80 resections, pancreas resections per month. In the years 21 to 2020, there were 11,736 operations with a 3% perioperative mortality rate. Most of these were pancreatic cancer, 8,395. What is interesting is that following the use of neoadjuvant therapy of between 3 to 6 months, even though there does not appear to be much in the way of tumour regression, in other words, the tumour still looks unresectable, it is possible to resect just over 50% of these patients, a little bit more with FOLFIRINOX compared to the other therapies. If we have a look at the survival curves of those who had a resection in this large series compared to those who did not have a resection, we can see that the median survival in those with no resection was 6.5 months, going up to between 14.5 and 16.5 months in those that had neoadjuvant surgery and then achieved a successful resection. Translating this in 3-year survival rates into the region of 28.1% in those that had FOLFIRINOX. It should be noted that within this group of patients who had a resection, 51 also had oligometastatic disease, i.e. small metastasis to the liver, for example, that could be resected at the same time, and these are included in the final analysis. So let's move on to our conclusions. For resectable pancreatic cancer, adjuvant combination chemotherapy is the standard of care. Neoadjuvant therapy should not be used. Only 70% at best achieve a resection. Chemoradiotherapy should not be used either in the neoadjuvant or the adjuvant settings. For borderline pancreatic cancer, neoadjuvant combination chemotherapy plus adjuvant combination therapy should be used, and the best evidence for this comes from SKMCH&RC. Neoadjuvant chemoradiotherapy should not be used. Evidence suggests that this is inferior. Only 60% achieve a resection. Further randomized studies, of course, would be welcome. For locally unresectable disease, neoadjuvant combination chemotherapy enables resection in some patients. the denominator is not known. In other words, we don't know the true number that benefit from having aggressive neoadjuvant chemotherapy, say, and then moving on to surgery. Nevertheless, resection after neoadjuvant chemotherapy achieves better survival than without resection. But it should be noted the recurrence rate is extremely high. And obviously, the pancreas community as a whole is working very hard to try and find new therapies for these kinds of patients. So acknowledgements to colleagues in Heidelberg and colleagues in Liverpool and elsewhere that it's my pleasure and honor to be working with. Thank you very much.
Thank you very much, Professor John Neoadjuvant, for that interesting talk. Pancreatic cancer, like I said before, is a very difficult disease to deal with, even in resource-high settings. And I think it was interesting that you touched upon the management of resectable and borderline resectable disease, especially given the current division within the various centers, whether they should go for neoadjuvant or upfront surgery for upfront resectable disease. This was very interesting. We would like to go for some questions, which we have. The first question is for Professor Andreev, and this is regarding the feasibility of preventive oncology, whether this is fruitful or whether that should be the focus of ongoing cancer research for the settings in low-income countries.
I'm sorry, I don't quite understand the question.
So the question is whether in low-income settings, there should be more emphasis on cancer prevention rather than treatment.
Well, surely preventing cancer is always going to be a useful step, because to prevent cancers prevents a lot of grief, and it prevents a lot of complications from the treatment, and it will save you huge amounts of money in the long term. So absolutely, I think prevention must be the key, but I think until prevention has really changed the outcome, we need to have everything in parallel, both prevention and treatment.
A question for Professor Neoadjuvant. I think this is in keeping with what I had mentioned earlier between resectable and borderline resectable disease. There is an emphasis on fast-track surgery in some of the UK centers in terms of pancreatic cancer with upfront resection. What are your thoughts on the difference between going for fast-track surgery versus going for the neoadjuvant approach?
You know, if you've got cancer, it's a good idea to start treatment as soon as possible. But what is that treatment? Is it straight to surgery? Is it improving the clinical status of the patient before you go to surgery? Is it having neoadjuvant chemotherapy before you go to surgery? So all of these are options. I don't think it's a magic answer, fast-track surgery. I think this is a gimmick put up by some people. I think what's required for every individual patient is the best possible treatment for that patient. If you're lacking resources, and this occurs both in developing countries as well as the so-called developing countries like the UK, you know, the resources in the UK at the moment are pretty poor for doing any cancer surgery. So in some ways, it's a non-question. So very simple answer is get on and treat your patients as soon as you can, but focus on the individual patient, not on some kind of target number. I hope that's not too confusing an answer.
I think that was really straightforward answer. I have a question here for Professor Andreev. Rectal bleeding is very common post-pelvic radiotherapy. When do you advise we use endoscopic treatments, and what are the APC settings that should be used for such cases?
So up to 50% of all people after pelvic radiotherapy will have some bleeding. So it's a very, very common problem. The most important thing in the first instance is to assess the bowel appropriately, make sure what the cause of the bleeding is. And then my criteria for treatment are three. So the natural history of radiation-induced bleeding is that it starts probably somewhere between 6 and 12 months. It may get a little bit worse, and possibly with IMRT therapy, the time of worsening is prolonged a little bit. So over the next 5 to 7 years, it may get a little bit worse, and then it will very slowly disappear over the next 5 years or so. So by 10, 12 years after radiotherapy, it's unusual to get significant bleeding. And then the criteria for treatment, I think, are three. If the bleeding is affecting people's quality of life, if the bleeding is getting onto their clothes and stopping them doing things, or if they are becoming transfusion dependent. And the vast majority of people, once they've been assessed, the bleeding is often very trivial and they don't need any treatment. Myself, I don't use endoscopic treatment with argon plasma coagulation at all, because I think the data suggests it's extremely dangerous treatment. You're using a thermal therapy in an ischemic field. And there's some data which suggests that 1 in 4 people will develop serious complications of argon plasma coagulation. So while it's widely used, there are very, very limited randomized trials to suggest that it's actually beneficial. And anecdotal and other data suggests that perhaps it causes a significant rate of complication in those people who've got really significant bleeding. So there's a number of publications on this topic, and I would encourage people, gastroenterologists particularly, to reconsider the use of argon plasma coagulation. It's so easy to do, but it has huge potential to cause harm.
Next question.
Yeah, so we have another question regarding the management of pancreatic cancer. We know that the radiotherapy is almost out from all phases of pancreatic cancer, but any news about involving stereotactic radiotherapy in locally advanced pancreatic cancer when it is still irresectable? Any data on use of stereotactic radiotherapy just to downstage the tumor when still localized, and then we can resect it?
Sorry, could you just ask the question in a simple way?
Yeah, so in a locally advanced pancreatic cancer, which is irresectable, what is the data of using modern radiotherapy techniques, the precision radiotherapy, which is the stereotactic radiotherapy?
Well, I mean, the best results come from Heidelberg with over 500 patients. And the best results are using systemic chemotherapy, not radiotherapy. There are no randomized control trials in the unresectable setting. In the borderline setting, as you can see from the Alliance 21501 trial and the Sjap05 trial, the chemo radiotherapy is inferior to chemotherapy alone. So I have nothing against radiotherapy. It just doesn't seem to work well in pancreas cancer. And, how many trials we do, they all say the same thing.
Yep, and it's quite toxic as well, because it's very difficult to target that area in pancreatic cancer. So
it is. And this is the argument for the Americans, not the Americans. Many radio-oncologists in America continue to use radiotherapy, saying, well, we have a better machine, we have a bigger machine, we have a machine that runs on diesel, not petrol. Now we've got electricity, now we've got nuclear radiotherapy or whatever, and there's always a reason to carry on using it. But the reality is that it is now in decline, even in the United States, as people face up to to the evidence that actually it's not in the best interest of patients to have radiotherapy for whatever reason. Experimental data, recent in genetically modified mice, for example, show that radiotherapy has a particularly deleterious effect on macrophage in the macrophage tumor microenvironment, actually impeding and hindering the immune response system against the pancreas cancer. So there are biological reasons. And although chemoradiotherapy is great for squamous cell cancers in the main, when you come to something like pancreas cancer deep inside, not squamous, it's deleterious, not beneficial.
Okay. So Dr. Fawad has been sitting quiet for a while. Dr. Fawad, it was a very good presentation and a very summarized review of the esophageal cancer.
Thank you.
You said that cross trial is the backbone now, and the trimodality treatment remains the standard of care in esophageal cancer. So what is your say on the dose of radiotherapy used in cross trial? Are we comfortable in giving 41 gray and going for surgery? Or because there is a difference of opinion in adapting this dose of 41 gray. So what is your say on this?
Absolutely. I think most of the centers across the UK and even here in Pakistan, they are kind of using slightly escalated dose of 45 gray and 25 fractions. And we even go up to 50 gray in those patients who we think have a borderline fitness and may never be able to go through surgery. So I think, you know, within the realms of between 41 and 45 gray neoadjuvant settings and up to 50 gray in radical settings is a dose which most of us will be comfortable with. I would, you know, I personally am in favor of using slightly higher dose than 41.3 gray. I mean, I use 45 gray in most of my patients, and because that has been the standard of care, you know, in the UK and across the US as well. So, and I don't think that in terms of toxicity, it adds very much. I mean, we again have to have an evidence, but you know, for 41.4 versus 45 gray, but it's very difficult to run that kind of a trial. Yeah.
We have another question regarding the role of utilizing screening endoscopy as a pilot study for Afghani communities with high prevalence of GI cancers. So I think this question will be directed at Professor Andrea.
I think Professor Fitzgerald needs to answer that question really, but I don't think she's on the call because that's her area of expertise. I'm sorry.
That's fine. I don't think we've got any other gastroenterologists on board here to answer that question. Moving on, I think, Prof, this is one of the questions where I think you probably would be the best person to answer, Professor John Neptolemos. It's the definition of borderline resectability in pancreatic cancers, because there are so many variations in their definitions across the world. A lot of our viewers would like to know what is your definition of borderline resectability.
Yeah, well, there are standard definitions that we can apply in randomized trials. The NCCN, the American guidelines, state what this is. I think they're all quite similar, but resectability has much to do with the center in which the operation is done. So what is borderline or not resectable in one center becomes easily resectable and resectable in another center. So this is why randomized trials are particularly important. The simplest definition is if there is any contact of the tumor using high quality contrast enhanced CT scanning preoperatively, touching, abutting on the superior mesenteric vein or the superior mesenteric artery in the case of head tumors, then that is defined as borderline. If the contact is more than 180 degrees in either case, then that is defined as unresectable. So more than 180 degrees encasement is unresectable. If it's between 1 and 180 degrees, then that's borderline.
That's very
You can also add length to that, like 2 centimeters. If it's less than 2 centimeters, it's borderline. If it's more than 2 centimeters length, it's unresectable. But you're right, it is a very awkward area. And so you can't really rely on non-randomized studies to draw any big conclusions on this. It has to be randomized. And at the end of the day, the studies coming out of SPAC and also Heidelberg, and Heidelberg is part of SPAC, are the best you're going to find.
Thank you very much for that. Professor Andreev, one last question to you, and then one last question to Professor John. With limitations of extensive diagnostic workup, such as no availability of CCAT, would you recommend use of antibiotics for small bowel bacterial overgrowth as treatment?
That's a really interesting question. Our work has shown that if you're very systematic and investigate patients with incredibly difficult symptoms, on average, you need to see them for 3 appointments, and you can make a huge difference to their symptoms. And then our other studies have shown that if you guess, you get it wrong all the time, or almost all the time. And I think there's a real problem that for a long time, the entire focus has been on how to cure the cancer. And that's an incredibly important question, without any doubt. But the question of quality of life after you've cured the cancer has largely been relegated and forgotten about. And follow-up isn't interested in quality of life very much. It's all geared to has the cancer come back. So this is why I believe that things need to change, because we're in a new era where people live for a long time, and lots of people are also on treatments which cause side effects, which if they stop the treatment, the cancer comes back, but while they're on the treatment, controls it. And we need to start thinking about these things in a totally different way. And all the diagnostic tests that we do, I do in my unit, can be done anywhere. You know, CCAT is difficult because it's not licensed in Pakistan, but it is available, and it's a very simple technique. And what I think is we need to have a paradigm shift to say that, yes, treating the patient's cancer in the best way is incredibly important. But we also need to start to say, how are we going to look after that patient once we've cured them? And I think when you talk to the patients I see, that they've often seen many specialists and they've often been dismissed. They've had lots of tests, but they've not had the right tests. And one can really change their outcomes if one thinks about it in a different way. And it has never been a priority of the oncology community up to now. And that's what I would like you to think about, is how you can change it. And nothing will change overnight, but without expertise in seeing people with side effects of treatment, you're going to struggle. So my own view is having a go, you know, when you have got no other option, is better than doing nothing. But developing specialized care for these people who really need it and who are really grateful to you for curing them is something that we really have to strive to achieve in the next few years.
So one last question to Professor John Ptolemus is regarding checking for BRCA mutations in resectable pancreatic cancer. Is there any role?
Well, it depends on prevalence, and in most populations, the prevalence is 1% thereabouts. So it's probably, for the majority, unless you're of Ashkenazi Jewish background, in other words, if you live in Israel or you live in New York, the prevalence is going to be quite low. So in the absence of family history, it's probably at this moment in time not cost effective, because it is expensive to do next generation sequencing on germline or even somatic The cost is very high, and you need a proper, qualified, registered, certified lab to do this. It's not a simple thing, because the mutations can occur anywhere along the BRCA gene, which is a very, very big gene.
That answers the questions. So we know at the moment in developing or low-middle countries. I think we're running out of time now, because I think there's a few more questions, but we're kind of running out of time. I would like to thank all our speakers for getting up so early in the morning to join us for the question and answer sessions. Definitely been a very informative and eye-opening presentations. Dr. Tabinda, would you like the closing comments?
Thank you very much. Now, Irfan, that's all. I think it's thank you very much from the depth of our heart. Actually, for this very informative session, it was actually very useful for the residents, the pancreatic talks, how we deal with the cancer survivors and what we are ignoring on the part as an oncologist, and a brief overview of esophageal cancer. So thank you very much for taking time out and being part of this wonderful session.
Thank you. Very well done. Thank you.
Thank you.
Thank you.
Good afternoon and welcome back to this second session of the Gastroenterology Oncology. Our second session is going to be more focused on the surgical side of things as opposed to the chemotherapy side of things. We have a wonderful session in front of us. We've got surgeons from various parts of the world, and they're all experts in their own field. The first person I'm going to introduce to you is Dr. Irfan Al-Islam. He is a colorectal surgeon by trade, and he's trained in minimally invasive laparoscopic colorectal surgery. He did his MBBS from Khyber Medical College in Pakistan, and then went on to do his FCPS, followed by FCPS in surgical oncology at Shaukat Khanum Memorial Hospital, Cancer Hospital in Lahore. Subsequent to this, he went to Portugal and worked at Champalimaud Center, where he had experience of robotic surgery as well as laparoscopic surgery. Then he worked in the Norwich Hospital, and finally joined us back here in Peshawar as a laparoscopic colorectal surgeon, where he is developing the services in this regard. He's going to speak to us about the role of minimally invasive surgery and the recent advances in colorectal cancer. So over to Dr. Irfan.
Assalamu alaikum. This is Dr. Irfan Al-Islam Nasir. I'm working as a consultant colorectal surgeon at Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar. Today, my talk is about recent advances and important controversies in colorectal surgery, what we all need to know about. So what is new in colorectal surgery? We will discuss all these important controversies one by one. But the treatment of locally advanced colorectal cancer is still challenging. And incorporation of new treatment options are being explored and continue to evolve. But what really matters for the patient? Is it the type of surgery we are offering? Or is it the type of perioperative treatment they are receiving? Or is it better short-term outcomes, better long-term oncological outcomes, and better quality of life? We will be discussing all these one by one. So first of all, the perioperative treatment, whether it improves the overall survival of the patient or not. So in Swedish rectal cancer trial, they looked into short course radiation therapy for the rectal cancer and found out better local control rates and better and lesser local recurrence rate in the irradiated group. But some of the centers was offering long course chemo radiotherapy. And when it was compared to the short course radiation therapy, randomized controlled trials were conducted, meta-analysis were performed, and all of them showed no difference in the rates of distant recurrence, disease-free survival, and overall survival. So what's the benefit for the patient? Is the time interval between the completion of the neoadjuvant treatment and the surgery. So one question should come in mind. What is the optimum time to operate after chemoradiotherapy? And if we delay the surgery, will it affect the short-term perioperative outcome? And as can be seen, there is no difference in the short-term surgical outcomes, and delaying surgery beyond 12 weeks was considered safe and feasible. Why we want to delay the surgery? Because there's a subset of patients who develop complete clinical response. And a more advanced concept in the multidisciplinary treatment, the watch and wait strategy, has also developed to minimize the long-term morbidity. So who are these complete responders? And who will be those ideal candidates? And are we harming our patients by deferring the surgery? These are very important questions, which I would like to address in the next couple of slides. As can be seen, low rectal cancer on endoscopy and MR imaging, when the patient received neoadjuvant chemo radiotherapy, it showed a tremendous response. And no tumor can be seen on endoscopy or MR images. Similarly, in another patient who received neoadjuvant treatment, and on subsequent imaging, no tumor was found. So the longer we wait, the better it is, and we will segregate those subset of patients who will show complete clinical response. But as more and more of these patients are building, there will be few who will develop local regrowth. But what is the best time to assess the complete clinical response? 8 to 12 weeks is considered the minimum optimum time during which a response can be seen. And those who are good responder can be offered watch and wait. So the longer we wait, the better it is. Basically, it is the test of time. So those patients who will develop local regrowth, so we looked into those and compared them to those who had persistent disease after the completion of neoadjuvant chemoradiotherapy. And they had similar perioperative short-term outcomes. So it means we can offer watch and wait, and if these patients subsequently developed regrowths, we can still offer them minimally invasive surgery, and they will have similar perioperative outcomes. So considering there is such an improvement in the rectal cancer care, there is a new Foxtrot trial for colon cancer, which is looking into the role of neoadjuvant FOLFOX chemotherapy in locally advanced non-obstructed colon cancer. They divided their cohort into neoadjuvant group and adjuvant chemotherapy group. To their surprise, there's marked T and N downstaging and tumor regression with neoadjuvant chemotherapy, with fewer disease recurrences within the last 2 years. They have also identified a subgroup of population who benefit the most from neoadjuvant chemotherapy. But we have to wait for the long-term results when they are available. So with this, we have covered almost all of the oncological side of the perioperative treatment. Now I would like to divert your attention towards the surgical side. We were at crossroads in early 90s when open colorectal surgery was well established. There was a lot of clinically published evidence, and it was considered oncologically safe. So the laparoscopic colorectal surgery came in, and it was considered a new technique with a long learning curve. And there was a big question mark on its oncological safety. Multiple trials were conducted, randomized controlled trial were conducted, meta-analysis were performed, and all of them were showing that there is increase in operating time in the laparoscopic arm with a variable conversion rate of 5 to 30%. But the early perioperative outcomes were favorable in laparoscopic surgery as compared to the open surgery. And above all, there was no difference in the long-term outcomes. So the first trial was a classic trial conducted in UK to look into the laparoscopic assisted versus open surgery. And they found out that 34% conversion rate for rectal cancer and higher complication rate and CRM positive rate in the laparoscopic group. We must keep in mind that was the time period when laparoscopic surgery was fairly new in the field. And later, the 5-year follow-up of the classic trial patient confirmed the oncological safety of laparoscopic surgery for both colonic and rectal cancer. During the same time period, the COLOR2 trial was conducted in Europe to look into laparoscopic and open surgery arms. And they found better perioperative outcomes in the laparoscopic surgery with a conversion rate of 17%, half of that of the classic trial, and 10% CRM positive rates in both groups. The Koreans have looked into it, the Korean trial. They conducted it from 2006 to 2009. And they found similar outcomes to the COLOR2 trial, and amazingly with a conversion rate of 1.2% and CRM positivity rate of 2.9% in laparoscopic group as compared to 4.1% in the open arm. As we can see, with more and more surgeons getting familiarized with the laparoscopic surgery, the conversion rate was reduced, CRM positivity rate was reduced, and the perioperative outcomes were already improved. When they looked into the 3-year survival rate, disease-free survival rate, overall survival rate, and local recurrence rate, they were comparable between the two arms. When all of this was happening, the North American looked into the pathological outcomes of the laparoscopic and open resections. And they found out that successful resection can be achieved in 82% of the laparoscopic group as compared to 87% in the open arm, with a conversion rate of 11.3%. But the most worrisome point was there was 15.4% rectal perforations in the laparoscopic group as compared to 9.5% in the open group. 9.5% was high in itself, but 15.4% was very high. But when they looked into the subgroup analysis, it showed that those surgeons who had more experience in the laparoscopic surgery, they had better outcomes as compared to those who were still in their learning phase. Similarly, the Oceania group conducted the a la carte randomized controlled trial, and they had almost similar outcomes to the ECOSOG randomized controlled trial group, with a conversion rate of around 9%. So these two non-inferiority trials raised serious concerns on the use of laparoscopic surgery in rectal cancer. While all of this was happening, the Europeans came up to address the issues of pathological outcomes with a laparoscopic transanal total mesorectal excision. There were multiple systematic reviews conducted, although there were small number series, and currently a randomized controlled trial is underway. When they compared the transanal total mesorectal excision to a laparoscopic total mesorectal excision, the systematic reviews and meta-analysis shows almost comparable outcomes. And when it was compared to a robotic total mesorectal excision, the short-term perioperative outcomes were almost comparable, but they raised serious concerns on the distal margin positivity in the transanal total mesorectal excision group. And currently there is a multi-center randomized controlled trial underway, but we have to wait for the long-term outcomes and results. The humans have evolved, and so is colorectal surgery evolving. The times have changed. And the minimally invasive surgery is here to stay. So the robotic total mesorectal excision There are multiple randomized controlled trials conducted. And as more and more papers are reporting better long-term oncological outcomes, urogenital functions, and its benefit in high-risk patients. So what was the dawn of the robot? The first robot was used in neurosurgical biopsy in 1985. And since then, the robotics have explored the medical field with more and more innovation in its technology. It's basically the natural extension of surgeons' eyes and hands into the patient with better magnified 3D vision, the instruments working like an endorest, and with enhanced ergonomics. So we are again at crossroads, as in early 90s. During the time period, at that time period, open colorectal surgery was compared to laparoscopic colorectal surgery. And now laparoscopic colorectal surgery is compared to robotic. And as the more and more meta-analyses are performed, they have shown that robotic resections are safe and feasible, with preferably better, if not equivalent, short and medium-term oncological and functional outcomes. And another randomized controlled trial showed robotic resection showed comparable CRM positivity rate to laparoscopic group with a conversion rate of 1.5% in the robotic group. And now the robotic resection is considered a good prognostic factor in rectal cancer surgery. And as more and more of the data is coming in, is showing a better overall survival in the robotic colorectal surgery patients and cancer-specific survival as compared to the laparoscopic group. Having said that, I would like now to share our experience with the minimally invasive surgery in the right-sided colon cancer. Initially, we used to operate via an open technique. Between 2011 to 2015, there was a transition phase from open to laparoscopic surgery. And from 2016 to 2018 onwards, we are offering more and more minimally invasive surgery. And 68% of the surgeries were performed using the minimally invasive approach, the conversion rate of 17%. When we looked into the short-term outcomes, they were all in favor of the laparoscopic group. And the long-term outcomes showed better overall survival and disease-free survival in the laparoscopic group as compared to the open group. When we compared them stage by stage, it showed better outcomes in stage 2 and stage 3 colorectal cancers as compared to the open resection group. We must keep in mind, as with the passage of time, the perioperative treatment have improved. It must have its role in the better outcomes of the colon cancer patients. So since May 2021, we have started surgical services in Shaukat Khanum Memorial Cancer Hospital, Peshawar. And so far in the last 5 months, we have performed 53 major resections. And all of them were performed laparoscopically with 0% conversion rate. The split numbers can be seen in the table. And when we conducted an audit of our elective colorectal surgery, we found out that the median length of hospital stay of our patients is 5 days. With the 30-day readmission rate after colorectal cancer is 2 days, 2%, and a reoperation rate of 1%, and mortality rate of 0%. So these must be good numbers, but as we are increasing our numbers, there might be some changes expected. So in conclusion, precision surgery is the concept, and minimally invasive surgery is here to stay. Teaching and training would bridge the skill gap, and patients who develop complete clinical response should be offered watch and wait strategy. And all of these can only be achieved in very closely supervised programs. As more and more clinical evidence in organ preservation is coming, there is a definite paradigm change. Whether organ preservation will be applicable to our cohort of patients, we don't know yet. But there are ongoing studies in Shaukat Khanum which may answer these questions, and only time will tell. On this technical note, I would like to say thank you. And if there are any questions, please feel free to ask in the end. Thank you.
Thank you very much, Dr. Irfan. That was a very entertaining and interesting talk. Next, we have Professor Irfan Ahmed, who's going to take on from where Dr. Irfan Islam left off, which will be the evolution of minimally-invasive techniques in hepatopancreatic biliary surgery. And we're going to talk about the past, present, and what's going to happen in the future. Just a brief introduction about Professor Irfan. He did his MBBS from Harvard Medical College, and this was followed up with an MD, which is a research degree from the University of Leeds, whereas his emphasis was on organ preservation, and did pioneering work on cold liver perfusion techniques in liver transplantation. He also did his higher surgical training in the UK, and that was followed up by becoming a consultant in NHS Grampian. He has the honor of holding 2 chairs, one at the University of Aberdeen and the other at the Robert Gordon University in Scotland. He's an examiner for the Royal College of Surgeons and advises the Joint Committee on Intercollegiate Examinations. He has more than 180 peer-reviewed publications and has over 100 scientific presentations, and has had a lot of funding done for various research projects in the UK, dealing with minimally invasive approaches in hepatobiliary, as well as management of complex hepatobiliary cases. Over to Professor Irfan.
Thank you very much for inviting me to talk on this symposium. I've recently joined Shaukat Khanum Hospital as a consultant HPB surgeon after working for 24 years in United Kingdom. One of my research interests has been history of surgery, and I was delighted to be asked to talk on history of HPB surgery. So let's talk about what is surgery. It comes from a Greek word, which means handwork, which makes all the surgeons manual laborers. But actually, to perform surgery is to eliminate what is superfluous, restore what has been dislocated, separate what has been unified, join which has been divided, and repair the defects of nature. Now, surgery dates back to old Egyptian history, where pictures of surgical tombs have been found in the ancient ruins. Inca surgeons in ancient Peru, they commonly and successfully removed small portions of patient's skull to treat head injury suffered during combat. Now, in 12th and 13th century, surgery revived in Europe, where barber surgeons who were skilled craftsmen will travel all across the country to perform amputations. They were showmen, and they will perform surgery in open audience, but they were lower in status than university-educated doctors. As I said, surgeons are showmen, and they would like to demonstrate their skills. In the past, surgery was performed in open theaters where people will come and pay money to watch a skillful surgeon operate. That's why we still call operation rooms as operation theaters. In the past, the problem with surgery was pain, bleeding, and infection. Although when ether anesthesia came in, it resolved issues with intraoperative pain. And the modern anesthesia has revolutionized the pain issues during surgery. Lord Leicester, who's called father of antiseptic surgery, his work led to reduction in postoperative infections and made surgery safer for patients. That's why he's called father of modern surgery. Then Wilhelm Röntgen, he discovered X-rays and described them on the 8th of November, 1895. And His work enabled us to see inside the bodies. So as Jack said, that evolution of surgery has always preceded by successive but irregular leaps forward. True innovative attacks that are systematically criticized and opposed by academic conservatism, but eventually recognized as positive advances. So as we see it, HPV surgeon performs surgery on these organs, but actually HPV surgery is performed around the cava mesenteric portal axis, which makes surgery more exciting for surgeons and more challenging. But due to constraints on time, I'm going to concentrate on liver surgery only. And liver has been a fascinating organ described in Bible. One of the Greek mythology, they described myth of Prometheus, where he was punished by Zeus because he stole fire to give back to mankind. So he was chained to a rock on the mountain, and every day an eagle will come and eat part of his liver. So every night the liver will regrow. So Greek, they did understand liver regeneration. Egyptians will remove the liver and place it beside the embalmed Pharaoh. So they also knew the importance of liver at that time. Liver has been taught as an organ of mystery in Arabic textbooks for 800 years. Church in 1500 permitted dissection of bodies of criminal, and Gleason described liver capsule in 1645, which we still use. But there were massive advances in late 19th century in HPV surgery. First hepatectomy performed in 1886, but patient died because of bleeding. Langenbach performed first successful hepatectomy, which requires a reoperation, and then liver resection started for liver tumors, and they were very small minor liver resection. Pringle came up with an idea of what he called Pringle pinch to stop blood supply to the liver, to reduce intraoperative blood loss. And then in early to mid 20th century, huge advances happened when arterial manipulations led to safer resection of the liver. And liver transaction techniques advanced, and finger fracture technique was introduced, which still is considered as one of the gold standard techniques. Goldsmith and Woodburn described liver into 4 segments, and that carried on till Conard in 1967 came up with the modern liver anatomy when 8 segments were described, and that's what we use today. And then liver surgery took another step forward with introduction of transplant. Thomas Starzl on the top left-hand corner, he performed the first transplant in 1963, but first successful transplant in 1968 in University of Pittsburgh. And then Professor Christoph Brolak, he was the lead surgeon in the first successful living donor transplant at University of Chicago in 1989. And that changed the face of surgery completely. And since 1960s, the mortality in surgery has been reducing significantly, and now we consent our patients by giving them 1 to 2% mortality risk. When I was growing up, I was told that big surgeons make big incisions. And this is what I was brought up with, starting all the operations with a massive rooftop incision. So if you look at the amount of tissues at dissection and in the anterior abdominal wall, that is one of the main causes of morbidity. In open liver surgery, we put our hands and instruments inside the patient and need a big access to get inside the body cavity. And these were the incisions that are part of the teaching by HPV surgeons: midline, rooftop, Mercedes-Benz, and reverse L. Now we have started introducing these cuts for our liver patient, no matter how large the patient is. In laparoscopic surgery, due to enhanced techniques in the cameras with 3D and 4K vision, have improved our vision during the operation significantly. Even difficult cirrhotic livers, adhesions underneath the liver, can be safely divided by modern equipment. Then in laparoscopic techniques, due to improved visualization and improved understanding of liver anatomy, availability of intraoperative ultrasound scan, we can perform surgery around major structures quite easily, and we can ligate blood vessels without causing much problem. And the techniques of controlling bleeding if something goes wrong has improved significantly. So we have moved from open surgery to minimally invasive surgery, and now we are moving from minimally invasive surgery to scarless surgery. Robotic surgery and endoscopic assisted surgery are somewhere in between that pathway, and further down the pathway is micro-robotic assisted surgery and nanocellular surgery, which I'm going to just briefly mention in my talk later on. Robot was introduced in 2000, but until recently, we did not know the huge advantage which a robot will bring. Now, initially, this looks like a standard laparoscopic surgery, but the 3D and enhanced vision, you can't see 3D vision in this talk, but you can appreciate the reticulating instruments both in the right and the left hand. A surgeon can control camera and all this equipment, and this makes surgery much easier and safer in the regions where it is difficult to reach laparoscopically. One of the biggest thing with robotic surgery is enhanced precision in performing very difficult tasks, especially in reconstruction. So this is a promotional video by Da Vinci, where they are suturing a grape using 8-O-proline, and you can see the precision with which these instruments are reconstructing the grape skin, which has been taken off by the robot. I'm going to skip this video further forward, but grape has been sutured safely. Precision is second to none, and that was all performed in a small bottle. So what are the improvements from open to minimal invasive surgery? So if you look on the left-hand side, there is a reduced length of stay, a reduced wound size, anesthetic ease, and reduced pain, causing enhanced recovery. But if you look at the left side, these are the improvements beyond minimal invasive surgery, which are linked to advanced robotic-assisted surgical technology. Because of precision and better vision, there is reduced blood loss, less risk of surgical complications. We can perform nerve-sparing operations. We can improve the margin clearance for tumor because of enhanced optics, angle enhancement, bloodless field, and better tools. And this all improves patient outcomes significantly. Now, one of the arguments against robot is the cost. But cost is not what is in operation theater. Cost is what is saved by improved patient outcome. These were the calculations which were done in NHS. The length of hospital stay in a ward is just over 400 pounds, in HTU is just over 600, and ITU is over 1,000 pounds. One blood transfusion costs 170 pounds, and if you have to convert from open to laparoscopic to open surgery, one conversion is about 2,000 pounds. And one complication can be anywhere between 3,500 to 16,500 pounds, and readmission is around 2,500 pounds. So the way I see moving from open to minimally invasive surgery is the procedure which are done laparoscopically should still be done laparoscopically, but the difficult operations which surgeons are performing open right now should be converted into robotic surgery, and that will cause significant cost saving in the long term. So we all like our equipment, We all like to use new technology. Surgeons are a bit of a show-off people, as we all know. They like fancy cars, but with all this equipment, important thing is teaching, and we need to know how to work the equipment which is given to us. So teaching and training on new technology remains very important. Now let's move into the future, where we see as the changing role of surgeon. So this is an article from President of European Association of European Surgical Association, ESA, and it says that it is called a robot, but it's merely a telemanipulator. So there are already predictions that AI, artificial intelligence powered technology, will outperform humans in surgery by 2053. So that's mid of this century. And I think I should have been retired by then. But the problem is, we should be concentrating on patient outcome, and these technological developments should not be driven by industry alone. So in summary, the advances in liver surgery are there because of better understanding of anatomy, physiology. We can manipulate liver better by doing portal vein embolization and ALPS procedure. We have moved to minimally invasive surgery. We understand surgical techniques better. There are better equipment and hemostatic techniques available. We are following enhanced patient recovery protocols, and the patient is out of hospital safely in a shorter period of time. Liver transplant is a massive step forward. But in future, augmented reality, stem cell treatment, and AI are going to be things of the future. So now in operation theaters, the dynamic scans are being introduced. The reason of dynamic scan is to give an accurate picture of liver during surgery, so that on the screen, we are not seeing liver as an opaque organ, but we are seeing liver as a transparent organ. So we can see all the vessels, color-coded vessels on the screen, and can perform surgery safely. Another further step is use of proper robot and not just telemanipulators. So these robots will operate through artificial intelligence independent of human beings and can perform surgery safely. These bots are used for trauma operations in war zones. But to my prediction, in next 10 to 20 years, they will become available in our operation theaters. So surgeons will not have a role to play because robots will perform surgery. So our group started looking into stem cell therapy as a cure for liver cirrhosis. And that's an interesting area forward, and I'm not going to go into detail, but stem cell is a fascinating organ. Undifferentiated stem cell can develop into any organs and can be potentially the foundation stone for personal medicine. In 2015, scientists grew organs using stem cells outside the liver. And as early as 2012, the scientists were successful in growing livers outside the human body. The problem is that technique still has not been perfected, but once it does, it will reduce the need of organ transplant because currently donor crisis is one of the big issues. And the liver grown from the patient's own stem cell will not have problem of rejection. So an interesting area to look forward to. So where are we going to go into future? We don't know. And if you look back in the past, even experts who pioneered these technologies got it wrong. So these are the historical quotes that Thomas Edison said in 1889, fooling around with alternating currents is just a waste of time. Nobody will use it ever. Albert Einstein thought that nuclear energy can never be obtained, and Bill Gates thought that 640K should be enough for anybody. So if these legends got it wrong, it's difficult to predict where we are going to go in the future, but still it's exciting looking at the past and present of liver surgery. We have come leaps ahead, and I believe there is an exciting future waiting for all of us in the future, which will enhance patient recovery, which will improve patient outcome. And I hope I can I can contribute a little bit into that future. So thank you very much. And I believe the question and answers will be at the end of the session.
Thank you very much, Dr. Irfan. It was a wonderful talk and well summarized about the innovations in hepatopancreaticobiliary surgery. Moving on to our next speaker, we have Professor Muntazir Mughal, who will be talking about effects of centralization in upper GI cancers and management of difficult cases. Professor Muntazir Mughal is a consultant gastrointestinal surgeon from University College London. And he has been a consultant for about over 30 years now. He did his MBBS in 1977. He had been a professor of surgery at University College London and has been instrumental in centralization of upper GI cancer services. He took his role along with being an advisor for NICE, Chief Medical Officer of London Cancer Collaboration Group, Examiner of Royal College of Surgeons, and Director of Cleveland Clinic as well. He has over 100 publications and 150 presentations, and he will be talking about his experience of centralization of services and management of some difficult cases. Thank you very much, Prof, and it's over to you now.
I'm very pleased to participate in this cancer symposium. And by way of a start, if I can just provide you with a little bit of background information about myself, to contextualize my talk. I'm an esophagogastric surgeon at University College London and also Director of Surgical Oncology at Cleveland Clinic London. For 20 years I practiced in the northwest of England before coming to London in 2011, and I have been involved in centralizing OG cancer surgery in the Northwest and then more recently in London. I'm going to talk about the experience of centralization, the benefits and the drawbacks, and also connect it with the second part of my talk, which is challenging cases, and there is indeed a connection between the two. Let me start by giving you a picture of esophageal cancer surgery in 1981. This is from a paper by Richard Earlham, published in 1984 when I was a registrar just in the middle of my surgical training, and it is a medical audit of esophageal cancer treatment in the Northeast Thames region in the year 1981. So when you look at these figures, they are not for the UK, they are not for England, they are just for Northeast Thames region. There were esophagectomies performed in 23 hospitals. 49 resections were performed by 37 general surgeons and 7 thoracic surgeons. You can then work out what the case volume per hospital and surgeon might be, and there you have it. Only 5 consultants performed more than 10 resections a year. The mortality was 35%. You could never get anybody to sign a consent form now for that sort of mortality, but this was accepted. And then the morbidity and the length of stay were also rather significant, with a mean hospital stay of 31 days. Well, that all changed with the Cancer Commissioning Guidance in the UK, which came out in 2001, which set out the minimum requirements of centres treating cancers, and for upper GI cancers this was the requirement that decision making was to be by specialist OG multidisciplinary team, a centre to serve a population of 1 to 2 million. That would yield about 250 cases, which would get to about 60 to 100 patients requiring resections a year. I've got that in red because that number is falling all the time as our imaging gets better and we find more metastatic disease at the time of diagnosis. that a center should have adequate ITU facilities, and that there should be out-of-hours cover 24/7. So that led to the formation of 37 centers in the UK that you can see dotted on that map around the country. And of these, 6 are in or were in London. They have now decreased in number, which is one of the centralizations that I've been involved with. And so coming back to my own experience, as I said, I'd been involved in the centralization in the Northwest, and that was in 2007 for a cancer network with a population of 1.7 million up there in area 2 that you can see there on the map. And then in 2012, after I moved to London, Northeast and North Central London, a much more populated area with 3.2 million population. Let me tell you about what happened with the centralization in the Northwest. You can see on this map now, just of the Northwest, the different cities and towns that had hospitals which did just a few, anything from 10 to maximum of 20 OG resections a year. And it was decided that Preston there would become the OG Cancer Centre and Blackburn would become the HPB Centre, and this is where the specialist HPB and OG surgery would be done. For Preston, we decided to invite our colleagues from Barrow, Blackpool and Blackburn to come across and join us to make a centre with 6 surgeons, and that started in 2009. You can see a team picture there before I left Preston, and what this shows is a true multidisciplinary team. So you got there a variety of nurses, from theatre nurses to ward nurses to clinical nurse specialists. You got dietitians, physiotherapists, we got 6 surgeons, we got specialist anaesthetists with skills for thoracic anesthesia, and we got trainees. So a truly multidisciplinary team that did esophagectomies 2 or 3 times a week and got better at treating these patients. If we look at the figures for the first 10 years of the Preston Centre from 2009 to 2019, they've been doing anything from 80 to nearly 120 resections a year, which has amounted to 1,010 OG resections in that time. And look at the mortality, 30-day mortality of 1%. Now, these are the sort of figures that when I was training, and we had those dreadful figures that I showed you earlier in the 80s, we were hearing these sort of figures from Japan and other centers in Southeast Asia, and we didn't understand how they got such good outcomes. But there is another sort of benefit of centralization, apart from the fact that increased volumes makes outcomes better, and that is training. So if you look at these figures, these were from the time that I was still in Preston. 2 of our registrars, Registrar A and B, one spent 18 months, the other 16 months. But look at the total number of resections that each one had done. So 63 for A and 60 for B, and that meant that as a lead surgeon, so I or a colleague would just be assisting them. Now, the important point about this is that without the volume, if you're only doing maybe 10 resections a year in a unit, you can't possibly train a registrar who's going to spend 6 months with you in doing these resections. They won't have enough cases, they will not see any complications that they need to know how to manage. So this is another great benefit of training. I then went to London, and I'm just going to show you what happened there. So the figures from 2012 to 2015, we centralized in London in 2016, is that for UCLH, which is in orange there, the orange bar there, and for Bart's Health, which is in blue, the 30-day and 90-day mortality was quite different. So one center, these are centers within 3 miles of each other, of having mortality of 0.7, 1.4, other 3.6, 8.8. We amalgamate the service and we get to a situation that the figures then are 30-day mortality of 0.6 and 90-day of 1.1 for the combined centers. So same surgeons working together, but of course now you've got an increased volume, you've got a bigger team, and therefore the whole thing works better. We jump on complications quicker and manage them better, and therefore the outcomes and mortality is better. And these are the figures from the National Esophagogastric Cancer Audit for 2020 in England and Wales, and the familiar funnel plot that you will know is a way of displaying the mortality and other data. And you got the numbers of operations here. These are 3 years worth of operations, by the way, not a year's worth of operations. So that center, which is us, is 150 operations over 3 years. And that's the mortality of about 3%. And the national mortality line is there, the green line, at about 4%. So a lot of improvement in the whole of the country, really, since 1981, and all of that is due to the operations being done in a fewer number of centers specializing in that particular sort of surgery. And the other thing about centralization is that you then have the benefit of the patient being able to receive the full range of interventions. So that means the endoscopic treatment of early tumors, the management of ultra complex patients with colonic interposition, etc. That's become sort of my particular expertise for the last 10 years, and dealing with tracheoesophageal fistulae, etc. And to give you an example, so endoscopic resection was something that we didn't do. We didn't have the skills for that in Preston when I worked there, but we did when I moved down to University College Hospital. And here is a case of a patient who you might think has just got a bit of esophagitis, but this is in fact an early cancer here, which is within an area of Barrett that had been under surveillance. And this particular patient was able to have an EMR rather than needing an esophagectomy. And here you can see the procedure. So you've got the mapping of the dysplastic and neoplastic area there. You can see that with the change in the light bandwidth, you can see it more prominently. And then it is time to raise the neoplastic lesion and mark it out, as you can see there. Yeah, and so now the submucosal injection to lift the tumor, the nodule, before it is resected. And of course, as you know, the EMR is done piecemeal. And there is one piece coming, and then once you've got the resection done, it's a matter of collecting the specimens, checking that there is no bleeding. You can see a very clean EMR there. Then you have a situation like this. So you've got these 5 pieces, which the pathologist was able to orientate and confirm that this was a T1A tumor, and therefore completely resected, and that the patient required this rather than this, which is your conventional specimen after an esophagectomy. And I reckon that if we had EMR facilities in the Northwest where I worked before, we would probably have done 15% fewer esophagectomies. So this is one of those advantages of having the skill set of the endoscopic expertise, the surgical expertise on one side. Now, what is the connection then with challenging cases? Well, it's simply this, that the more experience you have with the wide range of cases that you do, including managing complications, you get better at doing difficult resections, and therefore you are able to bring those skills for complicated cases, as I'm going to show you. So here are 2 scans, 2 cuts from the CT scan of a patient with esophageal cancer. On the left is a chest scan, and you can see there there's some thickening of the esophagus. And on the right is a section of the abdomen, and you can see there the liver. And I can tell you that the rest of the scan was normal. So this was T3N1 disease on the scan, except that this is not a normal case. So yes, this is an esophageal cancer, just like any other that you see, but this is a transplanted liver. So this patient, in fact, had a liver transplant in 1991 and then developed an esophageal cancer and was referred to me in 2012. So as far as the liver was concerned, you know, there was no issue with that. He was on the usual anti-rejection treatment, but now he had an esophageal cancer. Now, for the surgeons amongst you, here is the challenge, because when you plumb a new liver in, you do disrupt the normal vasculature in that area, and particularly the gastroepiploic artery, which of course we use to supply the stomach conduit, because we divide the other arteries in order to free the stomach up to do the reconstruction. And it was only because we had the expertise, the technical expertise, and also working with the liver surgeons who came across to work with me to deal with this situation. And remember, the patient, of course, would be on anti-rejection treatment, which would need to be managed carefully and would have some effect on sort of immunosuppression during this the recovery period. But he was able to have this operation with us at UCLH. I would never have been able to offer him that surgery when I was working in a smaller hospital with a smaller volume of cases, without having the multidisciplinary expertise to help. And you know, this is what he wrote some years later, that you know, the centralization, working with an MDT, felt to him like the best way to you know, get him through his sort of difficult situation of his esophageal cancer. So this was a picture taken with him at 82, and he only passed away of causes unrelated to his esophageal cancer 2 years ago at the age of 87. This is a patient that I've treated recently, and he had been treated at another hospital in the UK, and the story was that an esophagectomy had been started on him but abandoned. 67-year-old patient, T3N1, lower esophageal adenocarcinoma. He had undergone neoadjuvant FLOT, which he had tolerated well. The first part of his operation was a laparoscopic gastric mobilization, which was straightforward, but the surgeons were unable to enter the right chest to get at his esophagus. He'd had a serious road traffic accident a few years ago, had massive chest injuries with a right pneumothorax, right hemothorax, and when they tried a thoracotomy on him, the right thoracotomy, they just couldn't get in, and this was with thoracic surgeons. They tried in 2 separate rib spaces, just couldn't get in, and abandoned it. And he was referred to me, and we discussed the case at our MDT meeting, and we decided, well, you know, we had to find a way around this, and if the right chest was hostile, we could go into the left chest, but of course that poses some problems in terms of getting at the whole esophagus, but they're not insurmountable. So he had a laparotomy, a left thoracotomy, and a cervical incision. So here you can see the arch of the aorta, and the tumor is there. And then what we did was to mobilize the tumor and mobilize the esophagus below the arch and beyond it into the neck. You can see the brachiocephalic vessels up there, and then we did the rest of the dissection through the neck. Here is a picture of the esophagus completely removed from the neck down. So we've delivered that into the abdomen and pulled it down. And then the next picture shows you the panoramic view. We've got the left neck dissection there. We've got now the stomach conduit, and that is not the esophagus, which is here. This is in fact a stomach conduit, which is exactly the same sort of caliber, more or less, as the esophagus, and that is then pulled up into the neck. And here is the anastomosis in the neck, very high up, just below the cricopharyngeus. That's the thyroid there anteriorly. And that's the patient a few months later. The resection was an R0 resection, and he has recovered very well and is back living a normal life. So again, the skills that come from dealing with lots and lots of complex cases, which can only happen when there are lots of cases that you. So in the UK, with the centralization of the cancer surgery, we've also seen an effect on complex emergency upper GI conditions. There are 2 publications, as I have put on that slide there, that have looked at this. And what these have shown is that as the skills for dealing with complex upper GI conditions has sort of gravitated towards the cancer centers, then the management of complex benign problems is also going that way, what's called the passive centralization of benign complex upper GI surgery. And you can see here the figures from 1998 to the last sort of few years for esophageal perforation, for instance, there, which is that solid red line, paraesophageal hiatus hernias with complications such as perforation or incarceration, and even perforated peptic ulcer, PPU. So these are beginning to be managed in the cancer centers, and the outcomes are actually very good and better than they were before the centralization, because of the concentration of skills for cancer surgery which are applied to non-cancer surgery. And I'll give you an example again. So another challenging case. This is a patient who was referred to me with a tracheoesophageal fistula. So you can see on the bronchoscopy there this defect which has been covered by a stent, And what had happened was that the patient had been treated for a Boerhaave with stenting rather than surgery, and several stents had been put in and removed and put in, and eventually the patient got this fistula between the esophagus and the trachea just above the carina, which was covered with a stent just over there. And here is the thoracotomy with the stent that has been removed from the esophagus. And then you can see here we're looking into the trachea with the double lumen tube just there. So this patient needed really quite complex surgery to manage that fistula, to reconstruct the esophagus with a colonic loop, and benign surgery, possibly even more complicated than cancer surgery, but the skills that this required were available at our center. And again, this is a benefit of the concentration of cancer surgery. And there's the tracheal defect closed, and then an intercostal flap was put on that. And as I said, the esophagus was replaced with a substernal colonic interposition. So if this all makes it sound like centralization is a wonderful thing which hasn't got any downsides, well, of course, that's not true. It is and remains a divisive issue. So I'm just going to show you two newspaper headlines on the day that the cancer centralization in London was announced, along the lines that I was showing you about the centralization of OG cancer surgery and many other tumors. In the Times, you got this headline: "Revolution in Cancer Surgery aims to save hundreds of lives through specialist centers." And the calculation was that centralization of kidney surgery, urological surgery, OG surgery would save about 3,000 extra lives a year. And on the same day, a local London hospital carried this headline: that cancer services switch may put lives at risk, say doctors. So some doctors in the hospitals that were losing the specialist cancer surgery felt that if some of their surgeons moved to work in the new cancer centers, then there would be a knock-on effect for the non-cancer services, emergency services, and the net effect may be that cancer might win, but the non-cancer surgery might not, and lives would be at risk. So you can see that these changes have to be very carefully managed. To summarize then, the benefits of centralization are as on this slide. No doubt about it, as the volume increases, outcomes get better because you've got concentration of skills and resources, and it also makes it much better to resource centers better. I mean, if you are, for instance, going into robotic surgery, you don't want to have a robot, an expensive robot for every center that does 20 cases. Better to put that in a center that does a large number of cases. 24/7 specialist cover. You got the critical mass for access to trials. As I've mentioned, greater opportunity for trainees to learn, and then opportunity for innovation as well. There are drawbacks, as I said in that newspaper headlines, de-skilling or loss of surgeons who are relinquishing the specialist work, and of course some patients may have to travel greater distances to get to those specialist centers. It means that there are more steps in the patient pathway if the patient is presenting to one hospital and then is being referred to another hospital, which increases not just the traveling time but also the steps in the pathway, and the knock-on effects on other services, the so-called unintended consequences, because if you lose certain services, certain personnel, then say benign services might suffer. And there are places that say we find it more difficult to attract good surgeons because we haven't got the specialist services here that we used to have. So there is definitely a downside to that. And lastly, I of course have not had the time to talk about the research behind all this. So we're not just specializing, as I've mentioned to you, without studying it. So I'm involved with an academic group as well that has looked at several areas in this sort of centralizing cancer services. So this is, on what matters to patients and health professionals. How do you cost centralization? What is the cost of centralization? And an evaluation of the benefits, the pros and cons, as I've mentioned to you, and learning for provider networks. So if we are to centralize more services in the future, what can we learn about doing this well to make sure that we get more benefits than sort of disadvantages, and make sure that this is a cost-effective thing, which also is patient-centered in terms of improving outcomes. Thank you very much for listening, and I hope that I was able to explain my experience in this area, and look forward to receiving questions on this subject.
Thank you very much for that wonderful talk. Certainly an interesting concept, centralization of major cancer services, and the implication it may have for low or middle income resource countries. And it might be relevant to us. That's the questions we might be asking in the Q&A. Moving on, we have Mr. Michael Silva, who's going to talk to us about the recent management of colorectal liver metastasis. Mr. Michael Silva is a consultant HPB surgeon at Oxford University Hospital. He's one of my mentors as well. He's a clinical lecturer at Worcester College, Oxford. He did his MD in liver ischemia and transplantation. He's the clinical lead for islet cell pancreatic autotransplantation, as well as the lead for national database in IPMNB, which is the first of its kind. He's an advisor to NICE on HPB. He's on the editorial board of the British Journal of Surgery and other journals. He is a regional director of surgical networks for the Royal College of Surgeons of Edinburgh. He's a training program director for Thames Valley Higher Surgical Program. He's published over 80 research articles and has presented in many conferences. So over to Mr. Michael Silva and the updates that he's going to give us to us on the colorectal liver metastasis.
Good morning, folks, and many thanks for inviting me to join this prestigious meeting. My thanks go to Irfan Kabir, my friend and colleague, who has been instrumental in asking me to participate, and to the organizers of this meeting. My name is Mike Silva. I'm a consultant hepatobiliary surgeon based in Oxford in the UK. And I'll be talking to you about the management of colorectal cancer in the current context. And there will be some emphasis on the management of synchronous metastasis found with the primary still in place. And we all know that colorectal cancer is a common disease and afflicts nearly 1.5 million people worldwide every year. And at the time of diagnosis, most of this is metastatic disease, with the liver being the only site of metastasis in about 80% of cases. And we know that at presentation, nearly 20% will already have metastasis. Now, it is well known that stage 4 disease with metastatic colorectal cancer historically had a 5-year survival of a dismal 5% or so. But advances have happened over the years, and systemic chemotherapy has made the biggest impact, I think. In addition to us more recently understanding tumor biology and the effects of immunotherapy in certain states of tumor immune response. And in addition to that, we have been able to push boundaries in relation to surgical resection, stage resections, and combining surgical resection with other modalities like ablation and stereotactic radiotherapy, for example. All of these combined has improved survival from the 5% we talk about to up to 30 to 40%. And there have been over the years randomized control trials looking at the effectiveness of treatment, especially in those cases where there is metastatic disease, where we've considered long course and short course radiotherapy, for example, and chemotherapy for widespread metastasis. And these have had good level 1 evidence to support their use. But when it comes to surgery, and for that matter, managing synchronous lesions, there are no randomized controlled trials at all. So how do we decide on the timing of surgery for the primary and for the colorectal liver metastasis? When does chemotherapy fit in? Where would we use radiotherapy? All of these are based currently on historical data that come from case series that are looked at largely in a retrospective basis. Now, the old doctrine of limiting liver resections to lesions that only can be removed with a centimeter margin, fewer than 4 lesions in the liver, and absence of extrahepatic disease is out of the window. We do not consider these as our guidelines for offering liver-directed treatment. And currently, what we as liver surgeons look at is, can we remove all the deposits in the liver with adequate margins? And that's the basic premise of how we approach the disease in the liver. The other deciding factor is that we need to leave behind sufficient functional liver to do the job it is supposed to do. And roughly speaking, we look at about a 30% volume that we need to leave behind. But even that, we can circumvent these limitations by using stage procedures like ALPS procedures, for example. That is the use of associated liver partitioning and portal vein ligation for staged liver resections, and other hybrid combinations of surgery with, for example, ablation using pre-operative trans-arterial chemoembolization and portal vein embolization, or sometimes combining surgery with radiotherapy in the form of SBRT. So broadly speaking, we approach primary colorectal cancer with synchronous liver metastasis as depicted in this flow diagram. If we have resectable colorectal disease, in addition to the metastasis being resectable, we routinely now know that the use of preoperative chemotherapy will improve overall survival, disease-free survival, and therefore give you better outcomes. So that is not something that's debated on any longer. It's deciding whether we go liver first or bowel first, or do a multi-step, or do it as a combined procedure in the presence of a colostomy if it's a left-sided lesion, is the debate that we currently have still not resolved completely. And after liver-directed treatment, we'll always be looking at further chemotherapy or completion of cycles. And if the primary is still in place, obviously address the primary. Now, if you've got unresectable disease at the very onset, we will then consider preoperative chemotherapy, and if you can downstage it to a level that you could offer resection, you would then proceed to resection or liver-directed treatment. Obviously, there are new considerations, understanding tumor biology, which we will look at in the rest of this talk. So what do you do when you have a synchronous lesion? Do you go liver first, or do you consider treating the bowel first, or can you operate on both at the same time? And the traditional pathway was, as you will remember, that you'd first attempt to resect the primary, give some chemotherapy, and then progress to doing the liver surgery. But studies have shown that only about a third of patients actually make it through this pathway, and it is largely due to disease progression or side effects due to chemotherapy preventing the patients from having the liver-directed treatment. This interval progression might be also a feature of the patient declaring the tumor biology and therefore avoiding an unnecessary liver resection, which might not benefit the patient. But that was what we were practicing until in 2006, the group in Paris presented their experience of offering the reverse strategy, and that is addressing the liver lesions first, followed by targeted chemotherapy, and then the primary. And it's pretty clear when you are dealing with a lesion that looks like this in the liver, in the presence of the primary in the bowel, that if this large lesion is left to progress, you might end up with a disease that's incurable. Whereas if you were to address this lesion with a liver resection and then proceed with some chemotherapy and address the primary at the same time, subsequently, you would then end up with a better outcome. So the reverse strategy certainly has a place in our management plans. And understanding that the liver disease is what ultimately kills the patient is what we need to take into consideration when we make these sort of decisions. Combining liver and the bowel resection together is, however, a different question altogether. Now, what's the benefit of doing the bowel and the liver surgery at the same time? The benefit is that you get a one-stage procedure for the patient. You can plan your chemotherapy and adjuvant treatments better. It's obviously cost-effective, and with one hospital stay, it's going to be cheaper for the healthcare system. But is it safe? Is doing synchronous bowel and liver surgery at the same time safe? And this question was asked of the liver surgeons and the colorectal surgeons in the UK in 2011 by the team in Leeds. And there were significant concerns raised at offering synchronous resections by the UK surgical fraternity. And this argument still continues. And looking at a paper that's published just a few months ago coming out of Beijing in China, where they've looked at a large series of obviously retrospective treatment of liver metastasis in the presence of primary, using either the simultaneous resections, delayed or sequential resections. It has been shown in this and in many other series that simultaneous resections had a relatively high incidence of severe complications, while stage resections, especially that with delayed, had better outcome. Now, the difference between delayed and sequential is that sequential is where you resect the bowel and then proceed to resecting the liver without a period of chemotherapy in between. The delayed implies that you have chemotherapy and then go on to have the liver resection. And there have been many meta-analyses over the years, lots of studies with lots of patients showing that you can actually do the resection simultaneously with decent outcomes. But all of these are retrospective studies, non-randomized, and there's certainly a lot of selection bias when you look at them. And many studies have since shown that there is a subtle difference between doing a liver resection when the liver resection itself is a low risk versus a high risk liver resection, and whether the bowel resection is a low risk or a high risk bowel resection. And when you talk of high risk bowel resections, you're talking about the anastomosis, especially on the left side, or if it's a rectal lesion that is resected. And there's been lots of studies, again, case series that have shown that there is a higher morbidity with a high risk colorectal resection and a liver resection that is also major versus the opposite. And looking at whether synchronous resections are safe when you're looking at high risk bowel and liver resections together, there has been no definite conclusion in many studies that have followed. There was this study from Korea that came out a few years ago that showed that if you do simultaneous major liver with high risk bowel resections, your outcomes are relatively similar to that you would get with staged major liver resections. But again, this study is one that has a great degree of selection bias as well. So when you have a debate where there is insufficient evidence to back you up, and by that I mean good level 1 or level 2 evidence, you get experts, so-called experts in fields, getting together and coming up with consensus statements to try and help arrive at a solution for this sort of question. And there have been many such publications, as was this one, coming from a wide range from both sides of the Atlantic, led by René Adam in Paris, as did another coming from the European Society of Medical Oncology in 2017, trying to establish which is the safer option for patients with synchronous disease. So do we do the bowel first, the liver first, or go synchronous? And the answer really is that it is not one size that fits all. It has to be tailor-made decision-making based on anatomical location of the disease. By that I mean whether it's a left-sided or a right-sided bowel lesion, and whether the bowel is symptomatic. For example, if the patient presents with bleeding or bowel obstruction, the choice is obvious. The other decision-making tool that we now have in our armamentarium is the tumor biology, and I'll allude to that a little later. But this is something that we have started using more and more in Oxford in deciding on resections that would be major and would increase the risk to the patient, especially if there is a high chance of recurrent disease to happen very soon after the surgery. The patient's performance status and comorbidity is an obvious consideration, and the requirement for the patient to have, for example, chemo radiotherapy for a threatened margin of a primary rectal tumor will also define as to whether the bowel or the liver happens first. These decisions are complex. They require uniformity. In other words, there has to be the same sort of treatment pathway that happens time and time again for the similar sort of patient. And this is best done by multidisciplinary teams, as is how things happen in the NHS in the UK and in many countries around the world. It's an individualized treatment, and we know from evidence that multidisciplinary teams, or tumor boards as they're called in some countries, are the best way to decide on complex decision making in these sort of patients. The complexity of the surgery, we used to consider minor liver resections up to 2 Queenos segments and major liver resections up to 3 Quino segments, but we know that that complexity is not limited to anatomy alone. It has a basis to complex procedures. For example, we can now look at what we consider 3 groups of complexity based on anatomy: a wedge resection or a left lateral sectionectomy, which is just taking segments 2 and 3, would be considered a simple sort of resection, and a medium range resection would be an anterior segmental resection or a left or right hepatectomy, whereas a posterior sectionectomy, a central or extended right or left, would be considered a major complex surgery. This becomes even more complex if you add the caudate lobe in the resection, if you add the need for resecting bile ducts and reconstructing it, if there is a vascular reconstruction that is required. And it also depends on the center practicing. The center's experience also will lend towards whether the operation itself is complex or less complex. Other considerations would be portal hypertension, the use of the presence of post-chemotherapy steatohepatitis or venous congestion, the number of liver lesions that you need to resect, and the proximity to major vascular structures, biliary drainage, and so on. We also need to consider hepatic reserve. The size of the future liver remnant is a major consideration, and we do volumetry, ICG clearance, and a few other tests if we think that there is going to be an issue. And whether we do a non-anatomical or a parenchymal sparing type of surgery also takes effect. Now, for example, if we were to need to require to remove all of this, and we are only keeping that segment 2 and 3 behind, one of the methods we use fairly judiciously is an ALPS procedure, where we would transect and tie off the portal vein but leave the hepatic supply. And as you can see, this is a scan that happens 6 days post the stage 1, where you can see an exponential increase in size of that segment. And this is a similar case where a segment 2 and a segment 3 lesion has been resected, and the parenchymal resection done in the stage 1 of the ALPS. But there's no point doing this sort of major surgery if the tumor biology is poor. And we now understand that if there is KRAS or BRAF mutations, as you can see, we know the percentage of these happening. And if there is evidence of microsatellite instability, the prognosis is poor. And in these patients, sometimes doing such major procedures is not the right thing for them. And now it has become routine that we request for these genetic markers as well as biological indicators at IMDT, so that we can help decide, these can help us decide on the right treatment for a given patient. So coming back to the question that we started at the onset, should we go synchronous or should we go sequential? This will depend on whether you're doing a minor liver resection, for example, anterior sectionectomy or a left lateral in the presence of a right colectomy. Certainly we would do that. Could we do a major liver resection and a right colectomy? Certainly we would do that in a patient who has good performance status. Would we do a minor liver resection and a left colectomy? Probably in patients, again, who have good performance status. would we do a major liver resection and a left colectomy and give them a stoma? And this is a question I've asked colorectal surgeons. Would that be acceptable? And the answer to that has been, in most instances, no. And that is where we draw the line. We would not do a major liver resection and a left colectomy together. So whichever pathway we take, the overall aim is to maintain a low morbidity and mortality, and that would then translate to a better survival. And the emphasis has always been to use a multidisciplinary approach. And until we have better guides to help us select our treatment pathways, we will continue to go on with this individual treatment option that we offer patients. Thank you.
Thank you very much. Now, we all have been overloaded and overstuffed with surgical talks. Slightly changing the mood of this presentation, we will be moving to the next topic, which is recent advances in management of gastric cancer, which will be presented by Dr. Khurram Tariq. Dr. Khurram Tariq is a hematologist and medical oncologist at the Selby B. Jones Regional Cancer Center. And he's uniquely qualified as being triple ABIM board certified in the field of internal medicine, hematology, and medical oncology. So Dr. Tariq has made significant contributions in the global discussion, both in the fields of medical oncology, hematology, and nephrology as part of his other interest areas. Because we are already just behind time, so I'll just request Dr. Khurram Bilal to take over from here, and he'll be sharing his experience about advances in management of gastric cancer.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's such a pleasure to be addressing such a wonderful crowd. Before we dive in, just a little bit of introduction about myself. Well, I'm Khurram Bilal Tariq. I'm a hematologist and medical oncologist at CB Jones Cancer Center. I'm also the department chair and the director of the research department at CB Jones. I was the program chair for American Society of Hematology, ASH Live Review Pakistan, which was the first of its kind anywhere in the regions of South Asia or the Middle East. So really a proud moment for everyone in Pakistan. I'm also the founder of Hope virtual platform that many of you are a member of. And besides that, I wear several other hats within the APRHS network. This is a view of the CB Jones Cancer Center. It is situated in the beautiful town of Boone, North Carolina. An amazing place. The talk will be incomplete without mention of my motherly mentor, Dr. Fawzia Rana. Many of you may be familiar with her, as she was one of the founding physicians at Shaukat Khanum. This is her from that time. And then you have a picture of her with myself when she was the chair of Hematology Oncology Department at University of Florida. This is from 2015. All right, so the topic of our talk today is updates in mismatch repair deficiency and management of metastatic colorectal cancers. So let's just simplify this topic a bit. Mismatch repair pathway is essentially the pathway that identifies and repairs mismatched bases, which then plays a crucial role in the replication of normal cells. Any defect in this DNA mismatch repair protein pathway will lead to microsatellite independent instability. And that happens because of the accumulation of mutational loads. So mismatch repair deficiency is also synonymous with mismatch instability. It holds good prognosis in early stage colorectal cancer, and you can use this to forego chemotherapy in select patient population. However, it holds poor prognosis in patients with metastatic colorectal cancer. In terms of measuring MSI, it can be confusing at times. However, to simplify it, there are basically 4 different proteins that are accounted for: MLH1, MSH6, PMS2, and MSH2. Presence can be measured through immunohistochemistry, and then PCR could also be used to measure germline versus somatic propensities. Not all of those 4 proteins are created equal. Hall showed in this wonderful paper from 2019 that a loss of MSH2 and 6 carries a higher tumor mutational burden than a loss of MLH1 and PMS2. Now, this is significant because the relationship between tumor mutation burden, microsatellite instability, and PD-L1 is an evolving relationship because our understanding of the 3 entities is also broadening. Most medical oncologists throughout the world have been relying on PD-L1, but this is probably the least helpful of the 3. In terms of colorectal cancer, you want to be in a situation where you have a MSI high disease with high tumor mutation burden. And that ties into the type of mismatch repair pathway proteins that are missing that we discussed earlier. All right, let's dive in. Keytruda or Pembro really made ripples throughout the medical oncology field with this landmark study where it was studied for marker-specific but tumor-agnostic indication. So Bonwell basically studied 39 different types of cancers. Most of them turned out to be GI malignancies with higher propensity to have mismatch instability, with the exception of endometrial carcinoma. Keytruda was then used and showed significant objective response rate in both colorectal setting and also in the non-colorectal setting, with responses ranging from 27% in biliary malignancies all the way to 83% in pancreatic cancer. Of course, this study has its limitations due to a small sample size. But nevertheless, it was a huge leap forward in the field of medical oncology. And based on this study of 149 patients, Pembro was approved by the FDA in May 23rd of 2017 for the management of adults and pediatric patients with mismatch repair deficiency in metastatic or unresectable colorectal cancer or non-colorectal cancer, because it was tumor agnostic indication. And the field has just moved forward from there on. Here is the study of Checkmate 142, which was a phase 2 multi-cohort evaluation of ipilimumab and nivolumab in mismatch repair deficient metastatic colorectal setting. So in this setting, 6 different cohorts were studied. We will focus on cohort number 3, which included metastatic colorectal cancer patients that had mismatch repair deficiency, and EP and Nivo were used and compared with nivolumab alone. This study was presented at ASCO of last year. And what it showed was that 78% of patients had a reduction in tumor burden from baseline with combination EP and Nivo setting. The objective response rate was 55% in this patient population compared to 31% in Nivo alone. Based on these results, ipilimumab and nivolumab was granted accelerated approval in 2018 after they had failed oxaliplatin and irinotecan, which will practically be third-line setting for a lot of medical oncologists, as we tend to use FOLFOX and FOLFIRI in the first and second lines. This takes us to the blockbuster clinical trial, the Keynote 177, which was the first time immunotherapy was studied in the first-line setting for metastatic colorectal cancer patients who had mismatch repair deficiency. So in terms of his background, as we have seen earlier, 5% of patients with metastatic colorectal cancer have mismatch repair deficiency. And prior studies have shown that they tend to have higher tumor mutation burden with high levels of tumor neoantigens and increased immune cell infiltration. The prior study, which we briefly touched base on, showed good response in terms of objective response rate with nivolumab and ipilimumab. And there is another phase 2 study in previously treated MSI-high cancer patient, which also showed durable anti-tumor activity and acceptable safety profile. So on the back of these trials, current phase 3 study was carried out. This is the study design. So basically a randomized open label phase 3 trial with patients in treatment naive, so first line, mismatch repair deficient, stage 4 colorectal cancer setting with only the best ECOG performance status. About 307 patients were studied using either Keytruda or the investigator choice of chemotherapy modalities of treatment. And that included anything from FOLFOX, FOLFIRI, so on and so forth. A dual primary endpoint was used, which included the primary progression-free survival and overall survival. And the secondary endpoint was objective response rate and the safety profile. A very key point to consider here is that crossover was permitted from chemotherapy to immunotherapy arm. This will be the major topic of discussion later in this presentation. In terms of baseline characteristics, as you can see, most of these patients shared similar characteristics, except that the hepatic metastases were more common in the pembrolizumab arm compared to the chemotherapy arm. And they included patients from left and right-sided tumors. In terms of the progression-free survival subgroup analysis, most subgroups benefited from the Keytruda arm or the pembrolizumab arm. This included age, gender, ECOG performance status, geographic location, stage, BRAF, and the location of the primary tumor, the sidedness. As you know, sidedness plays an important role in prognosis of metastatic colorectal cancers. However, a key distinction here is that the patients with KRAS and NRAS mutation profiles tended to do better with chemotherapy arm. And you may wonder why that might be the case. An answer can be extrapolated from this progression-free survival graph here. As you can see that in the long run, the Keytruda arm tended to do better, and the chemotherapy arm did not do as well. The median progression-free survival in the Keytruda arm was double at 16.5 months compared to 8.2 months in the chemotherapy arm. However, it is important to focus on the first 3 months within the trial. And as you can see, within the first 6 months or so, there was a gradual drop in progression-free survival. For a lot of us who practice medical oncology, we know that Keytruda or pembrolizumab, like other immune therapies, do not kick in until after 6 months of initiation of treatment. And this graph tends to show that. Within the first 6 months, there was a greater drop in progression-free survival in the Keytruda arm compared to the chemotherapy arm. However, after that, the Keytruda arm did seem to stabilize, whereas the chemotherapy arm never recovered. It's also important, and this is just my expert opinion on this, that the patient, the subgroup that did not do good on the immunotherapy arm was, of course, the NRAS and KRAS mutant metastatic colorectal cancer patients. Imagine a person with a high tumor burden with KRAS or NRAS mutation, who is then started on immune therapy. Well, the immune therapy may not kick in for the first few months. And if you need an immediate objective response, fearing visceral crisis, then immune therapy may not be the way to go. Maybe these patients should be started on chemotherapy. And once they have stabilization of their disease, can potentially be switched over to immune therapy. Of course, this is just my personal hypothesis and is not based on NCCN guidelines. I will certainly start with chemotherapy on this select patient population who need an immediate response, especially in the initial setting, and then switch them over to immune therapy. In terms of the objective response rate, Keytruda or the pembrolizumab did much better with an objective response rate of 43.8% compared to 33% in the chemotherapy arm. Duration of response. So as we discussed earlier in the PFS slide, the duration of response was more durable in the immunotherapy arm. So a lot of patients do not respond to immunotherapy, but those patients that do respond have a durable response. So at 24 months, median duration of response was not reached for the immunotherapy arm, whereas it was 10.6 months for the chemotherapy arm. In terms of overall safety, the immunotherapy arm performed much better. In terms of treatment-related adverse effects, there were only 22 grade 3 or higher treatment-related toxicities compared to 66 in the chemotherapy arm. Of course, if you pierce the data, you'll see more immune-mediated side effects in the immunotherapy arm compared to chemotherapy arm. But from experience, we know that the immunotherapy is much well tolerated as a treatment modality and is often the preferred treatment of choice for frail, elderly, or patients with poor ECOG performance status. So in conclusion, the first analysis of Keynote 177 was presented at ASCO 2020 conference in abstract LBA4. And on the basis of superior median progression-free survival at 16.5 months, objective response rate at 43.8 months, and a more durable duration of response, and favorable safety profile with grade 3 or higher treatment-related side effects. Immune therapy was concluded to be the next standard of care treatment of choice in the first-line setting for patients with MSI-high metastatic colorectal cancers. So this really created a lot of ripples in the medical oncology field, and I know a lot of medical oncologists in the United States, including myself, switched over to immune therapy. It turned out that we were using immune therapy in a lot of these patients anyways, but with this trial, it was easier to get these approved with the insurance companies here. However, overall survival data was never reported. It never matured in the initial analysis when it was presented in ASCO 2020. So a follow-up final analysis was presented in this year's ASCO. The main focus of this analysis was to report overall survival. This was something that was awaited by the oncology community all throughout the world. In terms of the progression-free survival, here you have a comparison of progression-free survival when it was first presented at ASCO 2020 and then again in ASCO 2021. As you can see here, immune therapy maintains its superiority. And while the progression-free survival was double in the PFS1, it continued on the same trend. Median progression-free survival at PFS2 was 54 months compared to 24.9 months in the chemotherapy arm. So it was more than double, and it continued that trajectory. In most clinical trials, you will expect that to translate into overall survival. However, if you look at the overall survival data here, the hazard ratio was 0.74, p-value was 0.359, and you can literally park a truck in between these two curves of the immune therapy and the chemotherapy arm. However, due to the pre-specified threshold for significance, which was one-sided alpha, this overall survival threshold was never reached. If you ask me, I feel that the 60% crossover from chemotherapy arm to the immune therapy arm is to blame for this. As you can see here, that most subgroups in this study benefited from the immune therapy arm, even the subgroups that were KRAS and NRAS mutant. So it seems to me that this study was significant, however, just did not reach the pre-specified goals that the investigators had set for themselves. So why is there an overall survival benefit in the KRAS and NRAS mutant patient population? It seems that if the patients can survive that initial dip within the first 3 to 6 months, they will do okay because of the durability of the response, better objective response rate, and of course, the better side effect profile. In terms of objective response rate at the final analysis, it was 69% compared to 51%. Again, safety profile was much better as well. And so in conclusion, while it was not statistically significant, which to me is not fair analysis of this study because of the higher amount of crossover rate, this update basically confirmed pembrolizumab as the standard of care in first-line setting for mismatched, instable metastatic colorectal cancer patients. And this is what we are using. So here is a summary slide worthy of a picture that shows multiple immune therapy agents in multiple lines of treatment. And this is my crew from the infusion room. These are all the nurses. Thank you so much for your time from all of us. And we really appreciate being given the opportunity to speak at this conference. Thank you so much. Please reach out to me if you have any questions.
Right. Thank you so very much for that interesting updates in colorectal cancers. I think we've got one more presentation from the Royal College of Surgeons of Edinburgh. So I think the president has sent a 10-minute video and he would be talking next.
Hello and welcome to the Royal College of Surgeons of Edinburgh. My name's Professor Michael Griffin. I'm president of the college and I'm speaking to you from Edinburgh on a bleak late October evening. Here in Edinburgh, it is actually raining as I speak. I'm sure it'll be much nicer where you are in Lahore in Pakistan. And I know that this represents the 20th Shaukat Khanum Virtual Cancer Symposium, and I am absolutely delighted to have a welcome message to you. And in particular, I would like to welcome our first international surgical advisor from Pakistan, which is Mr. Asad Parvez, and welcome to him, to the college, and to his important role as an international surgical advisor. Now, I would have loved to have been at your cancer symposium as an esophagogastric cancer surgeon. I'm sure I would have had something to contribute and something to learn. And I'm sure that all over Pakistan, you will be settling down to this virtual symposium and hoping to learn much. Now, the college here has, I hope, a big future to members and fellows and those who aspire to be members and fellows in Pakistan. We offer a huge portfolio of educational support. Many of you may well have made yourself available to join our webinars across the piece during the COVID pandemic. We were doing educational webinars regarding the COVID pandemic and how it affected cancer surgery and all aspects of surgery during that time. And I know that you will still be amidst a degree of the COVID cases at the moment. Certainly we are still here in the United Kingdom. And the challenges that has brought to cancer surgery has been huge. I'm sure you're addressing a lot of these issues, but I can promise you that the Royal College of Surgeons of Edinburgh intends to increase its educational offering to Pakistan and hopefully to offer you membership exams of the Royal College of Surgeons of Edinburgh such that we can continue to support the surgeons of Pakistan going forward. It's been a pleasure to make this introduction, and I look forward, hopefully in the new year, in coming to Pakistan to firm up a lot of the educational offerings and, of course, the assessment and exam offerings that we have as well. Have a wonderful conference, and I'm sorry that I'm not going to be there to enjoy it at the same time as you. So enjoy the conference.
Thank you very much. Well, first of all, congratulations to Dr. Asad for becoming the Regional Surgical Advisors for the Royal College of Surgeons of Edinburgh. That's a great achievement. I think we are on to the question Q&A. Unfortunately, Dr. Khurram Tariq hasn't been able to join us for the Q&A, so I don't think we can answer the chemo-related questions for the time being, unless Dr. Tabinda has got anything to say about the questions.
No, I think we can forward these questions to him and we can get a reply and then send back to our this thing.
Okay. I'm going to just quickly ask the panelists a few questions. The first question is going to be for Professor Irfan Ahmed, it was interesting to see the robotic surgery and how things have developed with that. My question to you is that how do you see the robot taking over from the laparoscopic surgeon in terms of the liver itself?
Thanks, Irfan. I think robotic surgery is extension of laparoscopic surgery. And I don't feel that robotic surgery will take over from laparoscopic surgery, because the advantage which we get in robotic surgery is better vision, because it's 3D vision. We get articulating instruments so that they can bend and reach over difficult areas. Because of that, we can perform more difficult operations using minimally invasive techniques. So the way I see it in future is that surgery will move from open to robotic rather than from laparoscopic to robotic. So it's going to be a stepped approach when surgeons will start performing difficult operations with minimally invasive technique using robot. So robot is just a facilitator for surgeons to perform operations by converting open to minimally invasive. So most of the surgical specialties have started using robot. Evidence will start coming out slowly about the advantages and cost effectiveness. And I think in next few years, we are going to see more introduction of more non-surgical and surgical advancements, and surgical advancements are going to be robots and mini and micro robotic surgery.
And again, the question that everybody's going to ask whenever we talk about the robot is, number one, buying the robot itself at the current moment is fairly expensive for a low to middle income country. However, the issue most people have is with the reusables, because the price of the reusables usually is higher in the long term. And what are your thoughts on that? And do you think this is going to become more cost effective?
I think this is how all the pharmaceutical and medical device companies make money, by making these instruments disposable. So there are going to be more advances once Da Vinci has come out of patent, that more robotic companies will come in to make it cost effective. I think it will happen in future, and it's already happening, because what I've observed in Pakistan is that some of the disposable equipments are being reused with caution. There has been some studies behind them, and they're being reused with caution. I think same is going to happen with robotic surgery. And again, cost effectiveness is, yes, it might be more expensive to run in operation theater, but if you look at avoidance of complications, patient outcome, less hospital stay, eventually it will be cost effective.
And in your opinion, when will we see the first one in Pakistan?
I'm an optimist, so I hope soon. Very soon.
We have few medical oncologists saying that when we'll have immunotherapy, then only we can get robots.
So negotiation skills, I suppose. So my second question will be to Dr. Irfan. You talked very nicely about organ preservation in rectal surgery, and there is a lot of chatter in the research world and in the academic side, or in the oncology side as well, in terms of avoidance of surgery and avoidance of stoma and the complications that go along with it. In your experience, most of the, my thoughts are that most of the data that we're looking at is based on Western data. So in your experience of working in Pakistan as a colorectal surgeon, have you come across a lot of cases where there've been a pathological complete response, and where do you see this going for our cohort of patients?
Thank you for, first of all, thank you for inviting me. And yes, there are a lot of patients, especially in Shaukat Khanum, we have seen a lot of, like it's around 25 to 30% of the patients who have got pathological complete response. So now as more and more of the data is coming, and this is especially relevant to the people who have got low rectal cancer, and they do have complete clinical response. So now there is a slight shift in our approach as well, from operating these patients and offering them watch and wait, as most of these patients, when we look into the long-term data from the Western world, they have international watch and wait database. So there's around 30% of the patient who will develop complete clinical response. And when they have followed it for a longer period of time, they have seen that around 25 to 30% of the patient develop local regrowth. And those are the patients who develop, around 98% of the patient develop local regrowth within the first 2 years. And mostly it's a luminal regrowth. So obviously they can be offered minimally invasive surgery at that stage. So there is a potential benefit to the patients. So they can avoid surgery, they can avoid permanent stomas, and only time will tell.
Okay. And so on that,
I'll just add, sorry, the stringent follow-up and establishing clinical CR is very difficult in these patients. So yeah, we are getting good pathological response rates, but clinically following them every 3 to 6 months, getting scopes and biopsies, a bit challenging in our circumstances as well.
No doubt the logistics will always be a problem for our set of patients, because our patients come from very far-flung areas, and to follow them stringently and the surveillance is a problem. But obviously those who are willing to have those extensive follow-ups, we can obviously offer them.
And quickly, your thoughts on the role of robotic surgery in colorectal in the presence of 3D laparoscopic equipment?
So there is definitely a role of robotics. I've been trained in robotics as well, but obviously considering that a good quality can be achieved with 3D vision. But again said that robotics is obviously it gives slight edge in the low rectum where there is a tight confined space and the instrument can bend around in the pelvis according to the confines. So yes, there is some role, but obviously the time will tell.
You didn't seem very convinced there, but okay. Doctor,
I must add there, I think listening to all these talks were fascinating because the future, I think it's exciting for surgeons, but also worrying for surgeons because we can see all these non-surgical techniques catching up from all the other colleagues in medical specialties and basic sciences. So with all the new gadgets we're talking about, like robot, there is a possibility we will move to non-surgical techniques. So we might lose our job as surgeons.
I think the interesting thing was the stem cell. I think that was very interesting, and that will be something to watch for the liver part at least. Dr. Tabinda, there's a question regarding that pembrolizumab is not available in Pakistan. And there's a question for the panelists to say whether atezo in MSI metastatic colorectal cancer, should we do it or not? So I think Dr. Khanum's not here. So would you want to answer that question?
So pembro is not available currently in Pakistan, but the indication for atezo in MSI high colorectal cancer are not very clear and it's not been tested. It's just based that you get your PDL1 testing, and if they are positive, because we don't have any choice, we go ahead with atezo, but I don't think so that they can be alternated with each other.
Okay, thank you very much. I think we're running out of time. Thank you so very much to all the panelists for their time and efforts and setting up some very good presentations. Certainly, like Professor Irfan said, the future is bright and worrying at the same time. But hopefully by the time we retire, we'll still be in a job and the oncologists won't be kicking us out. So thank you, everyone. And all the best for the rest of the presentations.
Thank you.
Thank you very much. Have a nice afternoon.